Morning. Good morning, Nurul. Am I heard?
Yeah. You
Thank you.
are, audible.
Thank you.
Mhm. So, I have, informed my whole, audience that unavailability of Dr. Arpita. So, they are waiting for you on it. So, we have already made it live on YouTube as well as it is live on ismcon.in. And those who want to ask questions, they are entering into the Zoom room. So, there are some of them in the Zoom meeting room as well. And as you know, you came in, so most people are coming for a healthy discussion as well. So they are joining now on Zoom. So before wasting our time, let me introduce you so that because it's already 11:28, so we shall start our sessions today. We are with us. We are fortunate Dr. Reena Kumar is with us.
We'll wait till
She
11:30. I think 2 minutes. Let's wait because you said 11:30 doesn't matter. It's okay. I'm there. That's
yes.
fine. I
I
can be
have
heard.
enough time.
Everything is fine.
Yes,
In fact, today
I
we have no electricity in Goa, South Goa.
oh, Acha, you
Yeah.
are
So
in
there's
Goa, no,
some.
not in Delhi. Yeah.
I have come just 2 days ago to be with my parents.
Acha.
So,
Okay. Mhm.
so I am on mobile
Yes,
hotspot.
acha, but the connectivity is good and the speed is
I'm
very
glad for that. I'm
optimal.
happy.
Yes.
I'm very sorry to hear about Dr. Arpita's
Mhm.
mother. I mean, I had the good
So I'll
fortune to
just be
meet
waiting
her.
for your talk. Actually.
And
Yes.
I
So
had the
Dr.
good
Reena,
fortune.
yeah. Introduce you, Dr. Reena.
No, I was talking about Arpita's mother. I said, I'm very sorry to hear about that.
Yes, I think last week only. So I thought that she would be available, but still the rituals are on, so she is unable to join it. So all the ISM Conians who joined us today on the third edition, that is India International Sleep Medicine Congress 2024. We have our first speaker today, Dr. Reena Kumar. She is CEO IJCA Health. She is academic director ICANN Care, and she's also academic director IJCA Academy. She is academic director Indian Academy of Sports Dentistry, executive member Indian Sleep Disorder Association. She is regional clinical advisor, Special Olympics Asia Pacific, and she is secretary at IADH India chapter. Her area of interest is she is sleep-related breathing disorders in children, temporomandibular disorders, OSA and craniofacial pain, special care dentistry. She is very keen in interest area in sports dentistry. She's also interested in tobacco cessation and digital solution for health and education. She is a recipient of many awards, but I'm just giving you a brief. She is a recipient of CL Benson Gold Medal, best going students way back
I
in
think it'll
1980.
be okay, Narul.
And
Don't
the
worry.
recent award,
Don't worry. Don't worry. It's okay.
no,
It's
no,
all right.
I'm just giving. Yeah, we
People
have
in
a
our
time
field know
actually. That's
us.
why let me
I know.
yeah.
People in our field know
She
us.
is a
Most people.
National Dental Excellence Award Innovative Dental Entrepreneur in 2020. And she's a member of many forums. She's the National Director of Sports Dentistry, Indian Dental Association headquarters. She's National Director, ITA, Head Office, Special Olympic Health Programs. And she is very busy working closely with the Ministry of Health and,
Thank
working
you,
for,
Nurul. It's
yes.
fine. It's absolutely fine. So let me
Yeah.
just
So,
start
yes.
beginning by saying thank you so much for having me here, and I congratulate Ismcon, I congratulate the National Health Academy and for having hosted International Sleep Congress, third version of it. Very grateful so much for having me here today. It's great to have Dr. Ashu Sahu, who happens to be a very close friend, and of course you, Narul, and Irfanul, who I have been familiar and happy to be meeting on many occasions prior. So if it's okay, can I share my screen?
Yeah, please.
All right. At any point of time, if you find that my voice is unstable or something like that, I will switch off the video. Just tell me to switch off the video, I will switch it off because of the I'm on mobile hotspot. So once again, congratulations to the entire team for putting this, and that too to coincide with the World Sleep Day. It's as always, I say that you're a very proactive team and you really think ahead and work. I
Your
thought
voice
today's
is
day we would kind of try to talk about. Shall I just switch my video? Will that be better? Maybe I switch off my, just see if it's.
yeah, that would be better. You can maybe you can switch off your video and then share your slide, and the audio will come. Yes, you are audible, but your voice is
Hello.
cracking. I think this is the bandwidth in the network.
What is happening? Yeah, I have put it
Yes.
Is it all right?
Yeah, it's all right. It's good.
Thank you so much. Thank you.
And
So
your
I'll keep
voice is
the
also coming, optimum proper. Yeah.
This topic is what I thought because in the sleep medicine circles, it is that surgeons are mostly dressed in the form of appliances. But it's also important that we as dental surgeons should know, what is it that we can do with where sleep medicine is concerned. And we have so many 9 specialties, 9, 10 now with implantology, also 10 specialties. And yet we are not really certain as to how we can position sleep-related breathing disorders in a multi-specialty dental clinic. So with this, I'd like to carry on that Nurul, hello. Put it on a chat or tell me I'm heard. I'm audible.
Yes.
You're audible. Thank you so much.
Yeah,
Thank
yeah.
you. Thank you for confirming. Yeah, I
But
wasn't sure
slides are
because I couldn't see anybody, so I wasn't sure. Yeah.
yes,
So I
slides are
start again. So as I said that we are, looking at how we position sleep-related breathing disorders in multi-specialty. So to throw a few hard facts first, like as per the ICD-10, obstructive sleep apnea is listed as a sleep disorder, and snoring is a sign of disordered breathing during sleep, obviously. So collectively, OSA and snoring constitute the most sleep-related disorders. So I think as it is because OSA and is more purview in the domain of dental sleep medicine. I'd like to restrict the conversation today that we have and the meeting that we have to this particular topic itself. There is enough literature evidence that between OSA and there is a very strong relationship between the cardiovascular, metabolic, and neurologic systems and the insult that it gives to the general body. When you look at it to see literature, new publication which has come in, and this is as August 2023, where it says 2.4% of the men and 1.2% of women from general population are affected by OSA. Prevalence is higher in certain categories. Obviously, the obese patients and those who have suffered a stroke have more predilection for that. In the United States, the OSA in middle-aged adults is 10%, and for mild OSA, 3.8%, and for 6.5% for severe OSA. But it's estimated that 80 to 90% of the patients from the US with OSA remain undiagnosed. because of the awareness of this condition among the general public and general health professionals. So you can well imagine if the last is true, 80 to 90% is true in this country like United States, which we say is one of the most developed countries. And so what must be the situation in developing and underdeveloped countries? So, sorry, we have an update on just a minute. I think I'm not able to move the slide. Yeah. So is it moving now?
Yeah, it's moving. We are on an update on obstructive sleep apnea syndrome.
Yeah. So the prevalence of OSA diagnosed in varying criteria differs, you see, because the studies differ, but evidence suggests that snoring and OSA are very common among boys, more common among boys in children and those who are heavier, that to the boys who are heavier. Severity of OSA in children is proportional to the degree of obesity. More obese the child, the more the chances of the child having OSAs. The peak incidence is usually associated with 2 and 8 years because that's the time when the lymphoid tissues are the maximum and it's actually clogging in the airway completely. Later onset of this, particularly when associated obesity, is common between school children and adolescents. Now, what is the situation in obstructive sleep apnea in Indian population? So this is again a study which is fairly October 2023. So it says that the pooled prevalence of OSA is 11%, overall 13% males, 5% males. The pooled prevalence in severe is 5%. Based on findings, if we take this finding, then we say 104 Indians working age, only considering the working age, of whom 47 million have moderate to severe OSA. Now, so the people are suffering from, then we has got so many unmet healthy still there. Whether it's in our medical care, whether it's in our sleep, or whether it is from an infant, the mother, or maybe some young child, elderly or geriatric patients. So it's important for us to understand that, what is the knowledge and awareness that we have towards what are the diseases that they may be affected with, history and screening, how do we do a proper diagnosis, prevention, and of course the management. The most important one would be prevention. Now, because we are going to be talking about OSA, so I would like to talk about this disease, what it really is associated with. So if the congestive cardiac failure, obesity, hypertension, atrial fibrillation, and of course, hypertension. Now, this is a most scary picture that we have, and the scary picture really shows there's no part of the body or no disease that's really left out by this because of, so it's not only your cognitive disturbance and you're disturbing your bed partner, everybody else at home because of these snoring. Have various diseases, which are coronary disease, cardiac arrhythmias, congestive cardiac failure, sudden death, and all of this along with the GI reflexes, which causes a lot of dysuria, and name it, and we have it all right there. If we have it there, so what is it in the children that we have? So in the children, we would say that it's a spectrum which is there, starting from normal, which is primary snoring. So which could be primary snoring, going on to URAs, then obstructive hyperventilation, and of course the OSS. So in children, of course, we all that are more sensitive to it. Do not HI. One HI is not tolerable there. Your Respiratory Association Task Force to obstructive sleep apnea in children has defined this as a syndrome of the upper airway, right? And this can be potentially, obviously, because there's not the body at that time, there's no effort pronounced in the thoracic pressure. The child is having a lot of disturbances in sleep, so there's fragmentation happening, and there's oxidative stress and resulting in the metabolic disturbance which is going on at home. So a small child is actually developing these problems. So there is hypocapnia, hypoxia, oxidative stress, inflammation. And this is a dangerous physiology which is going on there. When there is autonomic activation, morbidity affecting organs, and the child is not sleeping properly, and at night we have all the growth hormones which are secreted. So there's a disturbance in the growth, there's a disturbance in the neurocognitive disturbances, quality of life, the metabolic, and of course, associated things, there's a nocturnal enuresis, poor scholastic performance because the child is never able to concentrate, never gets a REM sleep in there, attention deficit hyperactive disorder, and all of this coming into the quality of life, basically. So where we are going to see is that we have an adult OSA who has got a plethora of complex comorbidities and comorbidities which are there, morbidity and mortality, which is there associated with. And here we have children also, where we have the pediatric sleep apnea and all the associated problems that happens here. When you look at the update on the pediatric, there's a new update also, and it says it's a life-threatening, and it causes so much of neurocognitive and behavioral developmental as well as cardiovascular outcomes. And this low-grade systemic inflammation with increased oxidative stress, which is seen in, these children, is believed to underpin the development of these OSA-related morbidities. So this really requires that we need to really recognize and prevent pediatric OSA, and that is the one way ahead. Because if you can prevent it in a child, you need to recognize it and catch it really early. So we need to know where this is, because there are certain phenotypes which are there in this. So now when you look at literature again, and it says, how do we dental surgeons come into play? Because most of these characteristics are all in the craniofacial morphology. We'd find class 2 malocclusions, we'll find retrographic or backwardly positioned mandibles, we'll find maxilla, upper jaw being very narrow, the tongue being placed low, convex profiles that is showing that the maxilla is ahead and the mandible is far back, high palates, and all of these shows, that these craniofacial characteristics which are there are very characteristic of OSA children, and this may affect the cranial head position. So because the child is unable to breathe properly, and the person has a craniocervical extension with the head tilted upwards. So you look at, from the sleep medicine journals also, when it come out from Kate Sutherland, you have Lee, you have Sistoli, you see that you have all of the skeletal factors which are there in the maxilla, mandible, hyoid bone. The hyoid bone position is one of the giveaways. So when we take an X-ray and you see, which is a routine X-ray in most of our clinics where we have a cephalometry or a OPG taken, and you see the hyoid bone position, the cranial base, the face and the head position, the tongue, which is enlarged, the soft palate, which is enlarged, a longer uvula, the parapharyngeal fat pads. So all this is in the craniofacial region, you see. Now, all of this is actually coming out to be things which we can see are the summary when we look at the OSA patients. So many factors are all there in the craniofacial morphology. So when you compare the BMI, the AHI, and the different skeletal classifications, it comes out that there are these characteristics which are pointing towards that patients with sleep apnea. Now, you see, because my topic here is positioning, sleep-related breathing disorders, how do we get obstructive sleep apnea, the role of dentists. So there has been numerous articles. I just put up one because it's an interesting one. Consensus and controversy. So what is the consensus? Consensus, of course, is that it has been very well said from the American Academy of Sleep Medicine to the American Academy of dental sleep medicine, ASDSM, also says that, yes, dentists have a role to play in sleep medicine. But where is the controversy? And the controversy lies, can you work on it yourself? Can a dentist function by themselves and work on a patient with sleep medicine, sleep-related breathing disorders, OSA, or do you really need somebody else to work with? So the question is very clear that you cannot work alone. We definitely need to work with a sleep physician, a sleep medicine team. A dental surgeon is definitely a very, very important part and a very important team member of a sleep medicine team. The role really is, you see, the standards have been put up. This is an article which is 2020, this is 2022. And it says that dental sleep medicine standards for screening, treatment and management of sleep-related breathing disorders in adults using oral appliances. Of course, oral appliances is what we are talking about most of the time, and even in the physician circles, sleep physician circles, we are actually discussing most of the time who are not really highly sensitized to what we dental surgeons can do, or for that matter, even the reverse. We dental surgeons do not know what we can really do where our patients are concerned of different groups, age groups. So when you look at it now, it says, so what is our collective responsibility? What should be our collective responsibility? When I say collective, I just don't mean the dental surgeon. I mean also the sleep medicine physicians, the ENT surgeons, the neurologists, and all the people who work in this part of the sleep team. So skill up to understand the unmet health needs of our population. We really need to know, where is our population, where this particular health need, is it met or not met? Is it going underdiagnosed? Is it going non-diagnosed completely? Build awareness amongst our colleagues in the healthcare. Like, we as dental surgeons need to know within our healthcare system, that is within the dental surgeons itself, as to what is our potential. And while we are also going to be educating our medical professionals, our medical colleagues, as to what is the role that we can play in this. Build awareness amongst patients. Patients must know that when they come to a dental surgeon, they just don't come with an extraction or a filling or replacement of a tooth. They come with much more, because we are going to ask questions they're going to wonder why we are asking these questions. Work towards early diagnosis through training and through screening. Learning how to screen a patient, getting aware, because you're going to see something only which you know. Your eyes are going to see something, only something which your mind knows about. Screen for risk factors. Prevention is the mantra. I just read out a whole pile of risk factors which are there, and it's all there in literature. Going way back, orthodontic journal, general journals, sleep medicine journals, all of it says that the risk factors are in the craniofacial morphology and, of course, the phenotype of the child. Work towards inter and multidisciplinary management. Don't try to work in a silo. So if we work in a silo, now I speak from both ends, whether I am a dental surgeon or whether I am a sleep physician, but I work in a silo and I think I know it all and I can do it. But there are many things we're missing out, because we need to work together with a multidisciplinary and an interdisciplinary management background setting. Collaborate and train together to understand how we can together help the patient and reduce the global burden of the disease. Timely referral and continued follow-up. Like, there are some things which, if a sleep physician sees a child early, but he sends to an orthodontic or a pediatric dentist, there are a lot of things which can be resolved and which can be taken care of. Similarly, it has to work the other way around also, that when we work, we need a proper diagnosis. We've seen risk factors, but we need a proper diagnosis. And these diagnoses are most often made not just by taking a questionnaire or by looking at the risk factors, but there are sleep studies to be done. The polysomnographies, there are different 4 levels of them. And yes, usually we like to have the higher level of the study to be done. So our collective responsibility is very important. Not that, I'm a dental surgeon, I'm just going to delve into sleep medicine without any training or without anything. It takes years and years, and it takes a learning curve, and it also requires that you should be open to unlearn, relearn, and super learn. You have to be able to, discuss matters with the sleep medicine colleagues, sleep physicians, ENT surgeons, and all of that, and have an open mindset. Without that open mindset, to work in a silo in a dental clinic for sleep medicine is not really the best thing. So the situation would be like, we would need to look at patient care. So screening and risk assessment. As I said, how do we screen? So there are things that, as we go ahead in this presentation. Comprehensive dental sleep medicine focused medical dental examination and history, including the relevant imaging. Unmanipulative tests, assessments. Gathering and synthesizing information from sleep medicine patients to appropriately screen and establish a treatment plan, including there's an oral appliance, device fitting, calibration, long-term care. What are the others? So this is coming out of Sleep Medicine Journal. So I'm reading out protocol, which is not made by me. It is an accepted international protocol. Knowledge. So basically what I said is, without having a knowledge on the topic, or without having knowledge about what the patient is really going through, or what really is this sleep-related breathing disorder, we need to upskill, we need to scale up, we need to train ourselves. Basic sleep physiology, including the pathology, dentists and team members. So what is our role there? Urgent urgent, treatments and technologies. So you see, in sleep physician going to give oral appliances to patients, but we can do more. And this is what this presentation is supposed to elucidate, is intending to elucidate that in your dental practice, which you may have 9 specialists, 6 specialists, 5 specialists, or in a dental hospital setup, or in a dental clinic setup, or in a practice setup where you can have a good, what are the things that we can do? Learning and improvement, decision making guided by evidence, continuing education, even today, learning never ends.
Dr. Reena, your voice is not coming. You are not audible now. I think she get disconnected.
Are we all right now?
Yeah, now you are audible.
Are we okay now? Yes, thank you. So learning and improvement, we need to be continuous learning, reflective practice, and personal growth. Very, very important, reflective. Because when we are looking at a patient,
Your
we really need to think.
your slides are not visible.
Not visible?
Yeah.
Okay, I'll start sharing again.
Mm-hmm.
Okay now? Are we okay?
No, it's visible.
Not visible?
No, it's not visible yet.
Not visible yet?
Mm-hmm.
On?
Not visible. As soon as it comes on, I'll let you know.
Okay, I'll just move the location. I'm sorry, but today, because we have boys under entire thing is right now.
No, it was happening yesterday as well in virtually when we connect, we have a challenges actually for internet connectivity and device and all, not to, yeah,
Go.
you can take time.
Let me just if I can again move space for different area. But the hotspot says it is fine. Your screen is
visible.
it
Yeah,
says,
it's
right?
visible.
Yes. So I have moved out and standing outside in the garden. I think we are good here. So as I was saying, clinical knowledge is important, that all of us need to really scale up, skill up, and look at the various, when we give an appliance, even if I'm giving an oral appliance, let's say the most commonly known thing, an oral appliance, we should know what is it that is the patient really the right candidate for an oral appliance? What are the problems he or she is likely to have? What are the things that we are going to do with that? So all of this learning has to be there, and we need to be up on that. Most important is professional ethics, where we say ethical principles, accountability, and don't worry about including billing and coding practices, because what I have taken is from a journal and it is international protocol, and that's why I'm reading it out to you. So it is accountability and team training, subjective objective assessment, of course, the plan, we have an SOP, whatever we have of that, and how do you want to go about, that's your flow chart. Interpersonal and communication skills, effective patient communication, and barriers and bias mitigation, professional communication for enhanced patient outcome. I would say this is a very important one, very, very important one. Here, I said, presentation is all about how are you going to position orthodontist, oral and surgeon, a prosthodontist, and a dental hygienist. Very, very important. So the most important, as I say, we dental surgeons, every patient comes in for a scaling at least. They are the sentinels, because they're having the patient sitting there and they're chatting with the patient and the patient's mouth is open. You can see things, and early assessment of epidemic of mouth breathing. Now, this mouth breathing, what we say, is a huge epidemic. We all know the air quality is, Delhi or whatever, Mumbai or whichever city it is. And the air quality these days is what is affecting a whole lot of nasal allergies, whole lot of respiratory issues, because of which there is mouth breathing. Now, when there is mouth breathing, the patient is keeping the mouth open, cannot breathe through his nose, which is supposed to be the organ for breathing. The tongue is held low. The maxilla doesn't grow correctly. The transition, the mandible moves backward. Entire cranial is changing and growing factor voicing. So recognizing mouth breathing, craniofacial anomalies, I discussed that, aberrant functions of respiration and deglutition. If child swallow the right way, because it's a track like and the food down and the deglutition happens. And you saw that I know it's called an X-ray, which is the routine X-ray for us. Because patient's mouth is open, you would really know what you see of the airway. Tonsillar grading, aberrant functions, as I said, posture, craniocervical extension, behavioral and scholastic performances. So a history of how is the child doing, or the mother will say how harassed she is because the child is not functioning well. You start taking a history of what is going on in the home. Snoring and sleep assessment. The other question, sleep health, systemic health. What is the number of important there? So maybe many of us on the gums and nothing beyond, but where we look at is the body type. What is the obesity? What is the BMI? The next waist circumference. What is behavior? Is the child hyperactive, jumping around in the clinic, cannot be in one place? Is it dark circles under the eye, the venous pool? Is it drooping eyes, which, very typical? And is there a smile which looks that there's the smile in a row? Look at some does not have the hilar architecture is not uniform. Maybe it looks pinched on one side. Some kind of examination. We as surgeons are always looking at the mouth, so very easy to really patients. Mandible, how is the occlusion? Is it that it is wide or narrow upper arch? Does the palate seem very high? How is my and my both firstly sagittally, very important, as well as look at the nostril. So you can see the picture. You can see that the nasal alar architecture is different. So these are all giveaway things. We are going to take tonsillar grading, which is very easy for us to general dentist. Any one of us can always be looking at the patient because we advantage to. So with this, I say a screening or a risk, and of course, so you do not have to have any and in breathing disorders. What is it? Scale up for some training programs. There are lots of training programs available. Scale up for this. Attend CDs like this and specialized programs which are focusing on this, so that learn from somebody who's already practicing sleep medicine in the dental field, learn physician colleagues, and be and dentist to us. So how would we look at an orthodontist and a pediatric dentist does the role fit in? Very, very important role. The first thing I will say is, the gynecologists and the obstetricians are going to town always talking about breastfeeding. The immunologists talk about breastfeeding. We as dental surgeons, we are very quiet on this topic. because we feel that doesn't really concern us. But as orthodontist, as pediatric dentist, as general dentist, we should be loud and clear and talking about the importance of breastfeeding a child, because you may have a mother, a lady coming to your dental clinic who's actually holding a infant in the arms, or somebody who is in the stages of pregnancy, and you will have to counsel. Don't miss an opportunity, because what does breastfeeding do? We'll discuss that as it comes, and how it affects the size of the transverse growth of the maxilla. If the maxilla is growing transversely, upper jaw, your mandible automatically, the lower jaw automatically has space and area to move, advance forward. It will not stay backwards. So growing a child, the timely assessment and referral, therapeutic craniofacial growth modulations, which are done by functional jaw orthopedics and orthodontics, and very, very importantly, myofunctional orthopedics, which is orthodontics, which can be done, myofunctional therapy, transverse sagittal vertical dimension of the face. All of this is to be taken into consideration and can be affected and affected positively in an orthodontist and a pediatric dental setup. So you see, this is where we see about the, look at this picture on the left is you, when the nipple gets into the mouth and the child is breastfeeding, the entire nipple is there and the jaw is actually thrusting back and forth. Now, what happens is that the transverse growth of the maxilla is affected. When the transverse growth of the maxilla is affected, automatically the craniofacial structures are more positively impacted in here. Now, when you have the breastfeeding on the other side, the extreme right, so that is where you see that how there is a humerus there, because the tongue is going to lie low and the bottle nipple is going to be there. So, and the maxilla is automatically going to narrow up. So when it narrows up, there is going to be a change in the function. So the function of swallowing is going to change. The tongue position is going to change. And all of this is actually going to change the craniofacial morphology and make it more prone for your sleep apnea. So we need to know what is it about the differences between the adult and the pediatric, because we're always hearing, the child is very sleepy, EDS, but excessive daytime sleepiness. No, but this is a factor of more of the adult cases. Only the obese child will exhibit daytime sleepiness, but otherwise, if a child is having tonsillar hypertrophy, the child is not going to really exhibit this, excessive daytime sleepiness or somnolence. So it's going to be more that the child is going to be hyperactive. So here, parents report that snoring may be present. They say that snoring is a common finding in adult, whereas attention deficit, learning and behavioral issues, cognitive deficits, poor school grades, these are more common. So what are we supposed to ask? Now, the history that we are supposed to ask, if we have a child or if we are seeing something which is not okay in a child, what is the history we ask? So these are the histories, because the history that you take and the factors that you take in an adult and in a pediatric patient are totally different. You will have nocturnal enuresis in a child patient. While in an adult male, you'll have erectile dysfunction, you'll have things regarding, more of the marital discord. So here, PhD diagnosis HI5. So disturbance in sleep architecture. Here you have one. If one is not accepted, sleep architecture is usually normal in such children. So snoring in pediatric OSA is quite habitual, because you do find it all the time. It is also a factor which is associated with mouth breathing, snoring 3 times a week, PSG confirmation. So a pediatric sleep study is very important. A sleep questionnaires are there, pediatric questionnaires are available. Habitual snoring of 12%. With a 30-minute presentation, it is hard to go into each and every one of these things, but I'm giving you a general overview as to how an orthodontic clinic and a pediatric clinic can actually look and diagnose, pediatric sleep apnea, and what we can do here. So myofunctional therapy, as I said, myofunctional appliances, which have been there for years together, from the Pierre Robin syndrome days where it was given. And these every pediatric dentist is giving routinely. And what really happens is how it changes the patient of the maxilla to mandible in dimensions and brings about changes in function. RNA interaction is fast. So we have the rapid maxillary expansion with the protraction phase in cases. And here again, we have what really happens with an RME. It is very clearly said that in patients who have tonsils, if a lot of ENT surgeons and a lot of our colleagues, medical sleep physicians, will advise because tonsillectomy and adenectomy, as per the pediatric guidelines, American Association of Pediatric Guidelines, is also that is one of the treatments. You can go as early as 2 years. But the question is, it is very clearly said by the father of sleep medicine, right, that it cannot be the only treatment. You have to expand the maxilla. So your role as a dental surgeon is very important here, because a pediatric dentist, a general orthodontist will be able to do rapid maxillary expansion. And what really does, it improves nasal resistance, airway, and nocturnal enuresis. It is known to reduce the nocturnal enuresis, decreases the nasal resistance, and it improves it by 60%. And the mandible translates forward, because as I said, when the maxilla is expanded, automatically the narrow maxilla was not allowing the mandible, because the mandible grew. Then comes the mandibular sagittal growth, and only if the maxilla is wide enough will the mandible be able to translate forward. Anterior positioning of the tongue increases the oropharyngeal airway and betters the airway function. So all of this is in our offices. And there are also oral appliances, but they are not the oral appliances which a sleep medicine physician will actually be talking about. So these are things which we can do besides OAT. So we are going to be looking at what happens is an importance in the initiation of treatment time, because it's important that, craniofacial growth, most of it is over by 9 years to 10 years of age. So we have to catch them young, catch them right. Now, who's going to see them? The general dental clinic, because where the parents are coming with the children for their, routine, let's say, caries management or routine treatments, small gum boils, or coming for their own treatment, and you see the child along with them. So we have to be vigilant, because unless you actually see them young and you're actually managing the appropriate oropharyngeal function in the right time, putting in the airway patency, transverse dimension of the maxilla. I go on and on about the transverse dimension maxilla, which will manage the sagittal of the maxilla and the mandible automatically. Unless there are other issues like tonsils or adenoids, the things which may be obstruction or some such. Emphasis on the development of functions, because function is normal, form will follow itself. And in all the dimensions, when I say dimensions, I say transverse, I say sagittal, and I say vertical. I have a child.
Dr. Reena did this time. Yeah, he's coming.
Went off. आवाज नहीं आ रही है. हाँ, मैंने रोक दिया था 1 सेकेंड. ये लोड हो रही है स्लाइड, because I think I got disconnected. It is loading, so I'll just wait for it to be shared.
Yes, it's coming.
Yes.
It's visible now.
So now it's sharing. So yeah, thank you so much. And I'm really sorry for all this disturbance, but it's just beyond my control, because it is whole of Goa. So what I was saying is, so can we say as dental surgeons, putting our hand on our heart, saying that, look, I am here to treat the caries, the gum problems, the other issues. I will replace, fill, I will do whatever. But when the slide and you see, let the child, and I have not seen the child, I've seen the child, I've noticed things, but I have not done anything about it. And an untreated childhood OSS can go on for right ventricular hypertrophy, cord terminal systemic hypertension, reduced right ventricular ejection fraction in children with OSA under 7 years of age, increased left and right ventricular mass, elevated diabetes. OSA in adults, we know, medium to long-term adverse cardiovascular. So can you be vigilant? Can we be vigilant? Can we pick up the, what is staring at us? If we get a little more proactive and say, this is not something I want to keep on my conscience, I did not do as a child, grown and gone all these issues. So the mantra is when counseling. None of them expect anything like this from us dental surgeons. They don't expect us to ask how the child doing in school. That may be one of the real questions. You say that, look, I really want to know. Nobody's going to even the surgeons ask the king tongue posture, eliminate the pernicious oral habits. What we say, no, wo koi baat nahi, theek ho jayega. It'll become okay. Let him grow. He'll outgrow it. No, they're not going to outgrow it. They're going to grow something else. Develop the face to the full potential. Correct the transverse dimension of the maxilla. Correct the sagittal and the vertical maxillomandibular relationship. Institute correct function. Very, very important. Mantra number 3. Understand snoring. So snoring can be benign, can be a manifestation of pediatric of adenotonsillectomy. Now, in an obese child, if you do only adenotonsillectomy and not bring about changes in lifestyle, nothing is going to work. In a young child who is having, who is hyperactive, and you're seeing the child very young and is having disturbances, the mother says, I see him at night, his chest is going up and down. My patient tells me that इनका ना छाती बिल्कुल ऊपर नीचे जा रहा है, मुझे तो डर लगता है देखकर क्या हो रहा है. Some of them will even say they're blue, they're not comfortable. He gasps and chokes at night. So that is when you have to be able to look at a good ENT surgeon, refer your patient out, do your own imaging, understand what is there, look at the examination, get the correct history, refer rightly. Because as I said, nothing can we do by ourselves. Adenotonsillectomy needs to be done while at the same time the transverse dimension of the maxilla is instituted correctly before the growth is completed. So here we have adult patients. So you complete our domain, because once they are diagnosed, then team physician, but sleep physician to a dental evaluation, practice decision-making flow. And this is again from an international approved guidelines, which are given by the American Academy of Dental Sleep Medicine, where it says, it's a little busy slide, I understand, but I'll just tell you what it goes. So dental screening and examination. Do you suspect that the patient has OSA? It's yes or no. If it's no, continue to screen for whatever else. And every time he comes, again, start screening for OSA also. If indicated and in accordance with applicable laws, order a sleep study. In our case, if you're not, you should always work with a sleep medicine team. So ask for a sleep study or ask for a sleep physician, or a pediatrician who's working with a pediatric sleep apnea to have a look at this. So this patient, make sure that the patient is sent. You understand what has come out of the data. You understand the sleep study report. It could be a home sleep study for pediatric patients. It's a good thing to do home sleep studies. And then go to the medical provider for a correct diagnosis. Does the patient have OSA? If it's yes, then see what should be done here. And at the same time, what is it that we need to do? So if it's a child, is the maxilla mandible, is your cephalometric parameters, check out the cephalometric parameter. That is completely a separate lecture, which I can take for 1 hour to really explain what should be the cephalometric parameters and how do we understand and how do we get maxilla. So you institute things. So, and then it goes on. So then decision-making workflow chart, which is given out, and we can decide as to how it has to be flown. And this is not just in silo by a dental surgeon. So you see, you're working with a sleep physician team. You're working with a sleep medicine team, which may consist of an ENT. It consists of a pediatrician who works in sleep. You have a sleep physicians. You may have an endocrinologist. You may have a neurologist. You may have various people in this team. But definitely you need somebody who is well-trained as a sleep physician in this. So methods of how are we going to identify? So it says that, can you really give a mandibular positioning? So now it's an adult patient, so you want to give a mandibular positioning appliance. what we call as the OAT. So it is an oral appliance. So you can do it by two things. One is we say, okay, I will go by subjective. I will only ask the patient, how does he feel? So you take a questionnaire. So you're taking your Epworth questionnaire, you're taking your stop bang, and you're actually assessing, is the quality of life when the initial mandibular position, what was there? Then you say now, how is your quality of life? Are you sleeping better? What is happening? And verification. But see the last one, you have to get it verified by your sleep physician. So where they will go for a study. The other, which I will always advise because I work like this, is that I will always work with taking a sleep study. I will initiate whatever I am doing with a sleep study to get a proper diagnosis. And once that is done, and then from there on, work with a flow chart. So this is a patient who's here. He is a pilot by profession, and his whole problem was he was getting pain, and he would have he would never be able to eat in the pre-flight meal because he would make so much noise and there was clicking, he says, in the jaws. He would have hypersensitivity. He would wake up really tired. And, empty hours was never good for him. He says if he sat in the car, he would always sleep. He had pain in the back of the neck and he had pain on both sides of the face. So this is his occlusion. So you can see it's a very close bite and it's a deep bite. So there is gingival recession, there's attrition, abfraction. So abfraction is another factor which will tell you that at night is the patient kind of grinding his teeth or what is really happening. His metabolic the pictures like this: high lipids, borderline hypertension, diabetic, family history of sleep drugs. Orofacial pain, preauricular, sometimes headache in the forehead, difficulty in mouth opening, anterior displacement, and recapture of the bilateral. So that's it. Now, this is a sleep study. So it is a sleep study. And you can see this is another thing which is gives you a complete picture because I do a 12 channel sleep study. I do not compromise on that so that I get to see the leg movements. I get to see the jaw movements because there are the electrodes also on the masseter. I put on the mentalis. So all of this is there. And all the parameters are indicating to it that we can discuss this on another time. Joints, the TM joint pictures, the CBCT, which gives me the picture of what is really going on. So I put a diagnostic pressure point splint and then a trial CPAP, non-compliant to MAD. So that's how it was. So let's see whether it is. So combined approach of mandibular advancement and vertical opening for optimum effectiveness. So this is a bite gauge, George bite gauge. You use it and then do a recording, a wax bite registration. So this is another entire lecture which we can have on this. So the most important factor. So even the American Academy of Dental Sleep Medicine has given the guidelines for these oral appliances. So these are the oral appliances we're talking about. And these oral appliances can be a variety of ways. They can be, a single piece. It can be it can be how it is attached with rubber bands, elastics. It is attached with elastomers with a screw. So titrable, non-titrable, there are a whole lot of them. But I make titrable screws. So that is how it goes. And this is how the patient had this. This is a screw which is titrable, and I titrated out along with the sleep study to see how really is he improving or not, what is happening. So joint sounds reduced, the orofacial pain tenderness went away, sleep quality improved, quality of life improved remarkably. He was able to eat. He changed his job for a more high-profile pilot, and currently he is flying for the Adani Group. So this is a prosthodontist. What will a prosthodontist office do? So prosthodontists are people who are going to deal with no teeth, people who have no teeth. Now, people who have no teeth, the geriatric population, molars are the ones who usually are lost because they are decayed and they're going away. Okay, I can eat with it and things like that. How does it happen that an obstructive sleep apnea, neurocognitive dysfunction, and edentulous patient? So everything is very well recorded, you see, that every person has a role because when a patient has got no teeth in the back of his mouth, that is his molars are missing, his buccal segments are missing, there's going to be a collapse of the vertical dimension. When the collapse of the vertical dimension happens, then the tongue lies flat. So the tongue becomes more flatter, larger, and it automatically starts obstructing, the airway. It changes our one is, the tongue, the posterior pharyngeal wall, and the soft palate. It's so they're all magnetically pulled together. So why? Because you see, this is becoming longer, this is becoming flatter, and these muscles are becoming result. They all seem to think so. The dilatation compatibility or the neuromuscular control is also going away. So these patients are also. Now, the consequences when there is a change in that is there's a decrease in the vertical dimension of occlusion. We all know changes function of the orofacial musculature. So these are the changes which are happening now. So the tongue becomes big and flat and it covers up everything, and you can see where we are going into E. Macro is when depending on really the AHI. So many number of times the AHI can be very high when the patient is totally edentulous. But you put a denture in the mouth and then do a sleep study and see when you're restoring the vertical height, when you have put that effect wear on complete dentures on sleep. So the studies in sleep in edentulous areas can be these things: complete dentures on pharyngeal airway space, increase vertical dimension, and what is happening to the pharyngeal airway. So we have noticed all of it, that when a patient becomes edentulous, automatically the AHI becomes high. As it is muscular control much lower at that point of time, as you saw that things, then when the teeth are not there in the vertical segment, in the buccal segment, there is going to be a collapse of the vertical, and that's what happens. Subjects without teeth have a higher AHI and wider tongue. Maximum tongue width is there because of, the reason why. By maintaining the tongue and the mandible in a protrusive position during sleep, airway collapse can be prevented or minimized. So we can make different kind of appliances which are meant for the edentulous patient. So these are the various different ways that it can be done. So partial denture, implants, and airways. So this can be done. We can have a maxillary complete denture and a mandibular implant. Oral surgery, yes. The surgery is another thing which we can, a role is played by oral surgeons, because these are overlapping areas where an ENT surgeon, oral surgeon, plastic surgeon, everybody seems to, have a say in it and a matter work in. So uvulopalatopharyngoplasty, this is one of the surgeries which can be done. We all know what this surgery is. Lateral pharyngoplasty, genioglottal advancement, these are all by oral surgeons. These are all oral surgery setup in your dental hospital. It can be done. So partial glossectomy for those patients who are actually got, macroglossia, who have a huge tongue, can be done. And this is also something with an obese patient, which is a problem with many obese patients, that the tongue is very huge, or patients who have lost their molars very early and the tongue has adapted in all of it. There are numerous procedures. If I go on and on and on, this presentation will just carry on forever. The whole day it will go on. So I'm just palate. So this all great. So just kind of just saw that, yes, hygienists can do things, general dentists can do things, orthodontic, pediatric dentist, prosthodontist, oral surgeon. Public health dentists, of course, have a big role to talk wherever and whenever they have an opportunity, whichever place they go to, they must talk about this. They must be able to recognize this. They must be able to talk about the various issues surrounding it. But now, what are the challenges that we really have? So how do we have, what challenges do we have? So when you look at the studies which are done, this is 2020, and even the INOSA guidelines which was put out, that is guidelines for the OSA, was put out in 2014. It said very clearly, the studies are all showing that the medical curriculum, the dental curriculum, they do not know, the students do not know, they do not have much understanding about what is OSA. It is not really taught very well. Maybe a small chapter here, a small chapter there, but the applied aspect of it, starting from anatomy, physiology, pathology, how it goes on into medicine, into surgery, if it can be taken and pulled in as a complete curriculum, it has a lot of say in that. So despite dentists showcasing favorable attitude towards OSA, they possess poor knowledge for domain concerning screening, diagnosis, and treatment modalities. So special attention towards these domains need to be given to improve the handling skill of dentists for OSA coming to their clinics and prevent further health-related issues. So what does it show? It shows there's a skill gap. Of course, there's an unmet health gap, which is there because we saw the huge number which is there. So many millions and billions are there who have not been diagnosed or not really getting the appropriate treatment. But who will they go to? Who will they go to if there is a skill gap amongst us itself? Now, this is again a questionnaire which was done. Diagnosis and symptoms of OSAs were correctly done. So it was absolutely right. But only 11.4% of respondents felt that they were well equipped to diagnose OSA. General attitude of the participants was favorable with poor practice. So they do not have any practice skills. They can write a paper, they can write an exam maybe, they can write something and maybe pass, and maybe just get borderline marks. But when it comes to a patient, when it comes to clinical practice, they cannot do anything. 5.1% of participants were involved in the treatment of OSA. So that's how dismal a number that we are yet to. So at this point, I'm going to bring in something which, you see, every dental surgeon, every physician is, I just passed when I kind of viewed this place. I was in my final year and I thought this was a good place for me to start practice. But I've come back now a year and a half later, and I see, oh my God, 3 clinics already on my left, right, front, back, whatever, east, west, north, south. I've got so many clinics. So we are always scared of competition. We are always scared of competition. Everybody says, oh my God, I should be the only one in this area. But why should I be the only one? So how should I rise above the competition? I thought that if I have a very swanky clinic, if I have, the best operations in place, that is probably going to be the way. But from management sciences, we have understood that operational excellence is not a winning strategy, because there can be many who can have good operations, have an excellent way by which the patients are handled. They can have an excellent sterilization protocol. All of that protocols are in place, and the excellence is not really, that particular operational excellence is not really the winning strategy. But it's found that if we give our service offerings, so if I say my variety of service line is there, so I not only treat, a patient who has a dental caries, who has gum problems, who has a missing tooth, who requires certain surgical corrections of the jaws, but I also treat obstructive sleep apnea. So I have now changed. I'm working beyond my routine because I am skilled up and skilled up. So software change it in my dynamic from the competition. So the mantra now is, I use the word mantra a lot because that is what is going to actually tell us that where am I lacking? It is important to recognize that if you don't look, if I just look at somebody's teeth and the gums, I will definitely not see it. As an orthodontist, if I just see how crooked the teeth are or how badly malaligned vertically the teeth are, I'm not going to see anything. I'm not going to see POSA, pediatric obstructive sleep apnea, nor am I going to see adult sleep apnea. I'm not going to see anything. So first of all, gear up by education, by learning, by training, by taking CDs, attending conferences like this, taking courses with the prevalence rates up to 6%. So now the rates are up. And they said so many numbers from an estimated study, they found so many numbers in the USA and so many millions in India are all waiting to be treated. Because one, they don't know themselves, and the other, our dental surgeons don't know themselves. So, but these dentists in our practices, our dental surgeons have to now gear up to include dental sleep medicine in here. Simple steps to identify airway issues tomorrow can be the start. So today you have attended, the MedSkill conference, the third international sleep medicine conference here. And now tomorrow you should be able to start that. Okay, I start my screening tomorrow. Let my eyes start looking at things differently. Let me start modifying my exam sheet. So let me start asking questions like, does he sleep well? Does he kind of wake up at night? Does he have issues with, how does he move a lot on the bed? And is he choking? Is he gasping? Is he snoring? Is he having nocturnal enuresis? How's his school grades? Does he, start asking different questions to the patients and start focusing on questions related to breathing and sleep behaviors. Recognize other healthcare providers in your community with whom you can reach out for assistance when you find a patient about whom you are concerned. Very important. We may not know it just now. So when I started in 2007, that was my first case. And it just so happened, it happened to be my student, my postgraduate student. So I say a student is a teacher of a teacher. So I thank that student eternally for having, inculcated me into this learning where I did not know what was happening to her. So I took help. I sought, I read, I spoke to people, I spoke to physicians, I spoke to sleep medicine, I sought out sleep medicine physicians, and I started working with them. So do not ignore, do not feel inhibited, do not feel underconfident. When you reach out, you are showing you are eager to learn. Don't think of it that I don't know, that the other person is reading it as I don't know. No, the other person is reading it that, this person is very good. He has a questioning mind. He's asking why, what, when, how, what. These steps, you need to go around, look, I've done this particular course in apnea, in pediatric sleep, but I have so many patients coming and I do see such things. Is it like I would see can and at the same time, if patients like this, like to see the patients, holistic total care, ethical practice, very important, ethical practice. So don't try to do things which you're not supposed to do alone. Differentiate your service, bridge the demand supply gap. There is a demand and there is a very low supply. By meeting the latent and unmet health needs of the population, get better for it. Inter and multidisciplinary approach. We cannot do it by ourselves. We just diagnosis without a sleep physician, most often than not, you need to have a sleep study of some level or the other. Create your diagnostic and management workflow for your patient. And collaboration, say friends, is the only way ahead. Collaborate, never hesitate to collaborate. Talk to people, learn more, get going. Let's learn from nature again. This is a beautiful slide. I like it very much because these are two rivers. One of them is coming from, and how they meet. And this place, the most joyful places, it's in Geneva. Any of you been to Geneva? You see the meeting point of these two rivers. And as I see in our case also, when a dental dentist meets the sleep medicine, so dental sleep medicine meets sleep medicine, it's going to be the most joyful place for us because we are going to grow, learn, differentiate our practices, beat the competition hollow, and very importantly, create a very healthy life for our patients. And importantly, meeting the global healthcare needs demand of that, you're reducing it. Probably you're bringing in so much better quality of life for the patient. And I would say positioning dental sleep medicine, OSA in your dental practices, in our dental offices is not difficult. It is just that we have to have a change of mindset. So once again, I thank, Nurul for having invited me here. And this is really a delight for me to be here with amongst all of you. Nurul, thank you for giving me that extra time. And so I built a little more into it.
Yeah.
Thank you.
No, very enlightening. We are glued on our place, and every slides when we are moving ahead, it's a very mesmerizing, and I love to see, and you have spoken all the aspects of how to prevent actually how to directly, because dentists are the where patients is going
Sentinels.
first. Yeah.
So
I'm just getting a call from.
So there are any questions that anybody here in the audience would like to
Ma'am, Dr.
respond
Sonal
while
here.
Nurul is on the phone?
Yeah, Dr.
Yes, Sonal,
Sonal.
hi. Thank you for being here.
Thank you, ma'am. And it was a
Sonal, please tell
lovely
me.
lecture, and it was really enlightening. I'm also practicing since now 5 to 6 years. But the only issue, ma'am, what I face is the occlusal changes, if any, because it's a controversial topic. When we give any oral appliances, right now we have a lot of controversy going on behind it. So the occlusal changes, if any, like, ma'am, for me, the study is not that deep, like, 5, 6 years only. So have you faced any occlusal changes or change in the bite when patients are given these appliances?
Okay, so when you give these appliances, Sonal,
Hello?
Can you hear me?
Yeah, you are audible.
Yeah.
So I request you to read the guidelines. Very nice guidelines have been given. If you can share your email ID, maybe Nurul will share with me. I will share you the paper also. But let me tell you one thing. Before you take the patient up and give a oral appliances, though the sleep physician may tell you, okay, this is a mild case and the patient, or it's a moderate case and the patient doesn't want a CPAP, I think an oral appliance will be good. So we don't jump. This is where ethical practice comes in. We don't jump and put an oral appliance in the mouth. We get a complete examination done, a CBCT done, look at his TM joints, look at his occlusion, see what happens, put him on a slight advancement and see where is he actually functioning. So that is the first thing. Secondly, are there any loose teeth or not in the mouth? How are the restorations? What is happening to them? What kind is the appliance? Is that helping? Nasal obstruction is not that important, because if he has any kind of nasal obstruction, whether in the form of a atresia, turbinate, or a nasal, what you give, no, he's still having some deficiency somewhere along in his nose. So he's going to be using his mouth, and when he do that, he's going to start having some amount of collaborate your findings of the appliance with the know that the SPO holding. If there is going to be hypercapnia in the patient's mouth, he's going to start bruxing. And when he starts bruxing with an appliance, it's definitely going to have orofacial pain, TMJ, other things. So I would advise you to read this particular guideline, this guideline. It's a very new guideline. And the other thing is examine your patient rightly. And most important is give the morning exercises so that you give him a shim and ask him to change his bite and get his jaw in order, move open, and also a warm towel on his face. When he wakes up, a warm, moist towel, moist towel. It should be a chota face towel, which you put it, ask him to put in warm water, hot water, squeeze it and place it on the thing, and then do some blowing exercises. All of this usually helps the patient settle in the mouth. And many times, Sona, what is important is when you see that these patients are having not too many problems, if are they really following this regime of settling their muscles and the jaws in the morning when they wake up, to the benefit that they are receiving compared to what the problems they were facing. So the risk benefit, cost benefit, are a very important part to be done. I hope I've been able to answer your question, Sonal.
Yes, ma'am. Thoroughly, ma'am. I'll definitely get in touch with you, and Dr. Nurul will help me, I'm sure on that. So thank you, ma'am. And it was really an enlightening lecture.
Of course.
Glad that I attended it. Thank you so much, ma'am.
I hope that I have inspired others to start the way you have already initiated yourself. I want every dental clinic actually to be a place where dental medicine can be.
Yeah, Dr. Reena, it's quite motivating actually. You know, your main key word is that to collaborate and not to work in silo. So the every dental clinic should be equipped with early diagnosis of all, because they know this cephalometric parameters, they know the craniofacial architecture, they know the growth, etc. And every clinic of dental surgeon must have their pediatric sleep apnea questionnaire, pediatric sleep questionnaire with them. They should ask questions, take diagnosis, sleep properly, and they should work in a collaboration with sleep medicine ENT surgeon to diagnose the case as early as possible. And there are we have the scope to early intervention if we have, so that we can make the changes in the orthopedics of orofacial the architecture and this orthognathic bones and all. So this is very motivating to all those who are dental surgeons who are in our meeting room. They're very motivating for them, and they will from tomorrow onwards, when they are going to every clinics, they keep on eye and they started screening those cases of OSA in early diagnosis and all. Thanks for joining and sparing your time.
So your orthodontist, your oral maxillofacial surgeon have a huge scope and huge role to play in sleep apnea cases. That's also the message which I'd like to give to our sleep physicians and to ourselves. Most important to ourselves, that we should not restrict ourselves to only oral appliances, which are understood by the medical side, but we have a bigger role to play. Thank you so much.
Thanks, Dr. Reena. With your permission, we are moving to our next speaker.
Yes, thank you so much. Thank you.
Yeah,
I will try to stay on, but just
please,
in case
please.
I'm kicked out. Thank you so much for this opportunity, and best wishes.
Thanks, Dr. Reena. Thanks. So we are with us, Dr. Sanjay Manchanda. Dr. Sanjay, can you open your camera, if possible? Dr. Sanjay, am I audible to you? Can you unmute your microphone? Dr. Sanjay is in meeting room, but I think. Yeah, Dr. Sanjay, you are visible. Can you unmute your microphone? Yes.
Can you listen to me?
Yeah. You are audible. Yes. Dr. Sanjay, I think your device is, out of order, it's not functioning. So you would be, talking for yes.
Well, thank you, Dr. Anwar, for
Sir.
giving me this opportunity.
Let me introduce you. I'll just give you formal introduction before you start. I'm just
Okay.
introducing you. Yeah. Dr. Sanjay is a stalwart in sleep medicine. He is first in the country to start sleep medicine as an independent department at Sir Gangaram Hospital from 1996 onwards. So he is the first to start home sleep studies from 1995. I start sonoplasty for the treatment of snoring on OPD basis with ENT surgeons. First to start dental sleep medicine in India with orthodontist. Developed the first mandibular advancement appliance for the treatment of snoring and mild obstructive sleep apnea in India in 2002. And he is first to start sound and music therapy for the treatment of insomnia. First to start the networking of sleep center across the country and distant reporting of sleep studies. Excellence in developing sleep medicine by World Medical Council in 2016. He is presently working as a chairman, senior consultant, Department of Sleep Medicine, Sir Gangaram Hospital, New Delhi. And he is practicing sleep medicine for last, say, 2.5 decades. And he already have 3,000 sleep studies to his credit. So this is a brief introduction of Dr. Sanjay. He's a pioneer and bringing the sleep medicine, establishing sleep medicine specialty in India. Over to you, Dr. Sanjay. If I forget anything, you please add on and then you start your, discussion.
Well, then, first of all, thank you for having me here. And I'm sorry to the people because my laptop conked off. And unfortunately, today morning itself, and I do not have access to the Wi-Fi on my laptop. So I'll be talking more, without any show. But let us see that if I can convey something to the people out over here. And I'm very thankful to you, sir, for, such kind words for me. And the number actually 23,000 is now 26,000. Just to be on the other side.
It's a last profile in 2022 when
Yeah.
we conducted
I
profile.
totally
Yeah,
agree.
I have.
I totally agree with you. Okay, the thing is, the subject that I'm going to talk about is what everyone should know about sleep. The reason being, it is still an enigma, and a lot of people do not understand, including the doctors who are treating the patients and taking it very trivially. So we need to be a bit more objective in our view, and we can get, because I'll just go around that. Reshaffen, the man who staged the sleep, he said that if sleep does not perform an absolutely vital function, then perhaps it is the biggest mistake the evolutionary process has ever made. So taking away 1/3 of our lives for nothing, I don't think nature is that very unkind. There has to be a reason for that 1/3 of the life, because it is extremely important for all of us. Now, what exactly is sleep? In the simplest possible words, it is the natural periodic suspension of consciousness during which the powers of the body are restored. Small but effective. The functions of sleep are restoration of the mental and the physical functions, entering the information for memory consolidation, re-establishing communication.
Dr. Sanjay, I think he this connected now, and he's trying to join again. Just wait for it. Sorry for the inconvenience.
Hello, can you
Yeah,
listen?
you are
I'm
audible, sir.
sorry, this is the fallacy on talking on telephone, which I could not have averted. It just came in. Anyway, re-establishing the communication between the various parts of the brain and to restore their energy and repair of the tissues. So sleep is still an unresolved puzzle, or basically, it is an area where still we are not very sure of a lot of things. But every day we are adding a new dimension to it, including the ailments as well as the, say, response to those ailments. As a society, we are sleeping by less than 20% in last 100 years. And averagely, we are restricted by, say, 1.5 to 2 hours. This was a report published in 2007 in Journal of Clinical Sleep. And the important part is that we are basically a sleep deprived society today. And it is because of the artificial light that our days have become very, very prolonged. So, as far as sleep is concerned, if you can say understand, there's a lot of estimated cost to the sleep deprivation, because it causes a huge number of deaths, countless injuries, disabilities, accidents, and healthcare expenditures. So the first one in India is 1984, the Bhopal gas tragedy, and almost 500,000 people were affected, 20,000 dead, and a lot of loss of to the exchequer. Chernobyl nuclear power plant disaster in Ukraine, 1986. 3.4 million people affected, half of them children. This was the world's worst peacetime nuclear disaster. So there was Exxon Valdez oil spill, which was the biggest oil spill. And for the first time, it was labeled by National Transport Safety Board of USA that sleep deprivation was the cause. And in, say, Alaska, around 2,000 people on a Star Cruise ship were stranded because of the rupture of the water tanks, the petrol diesel tanks. And advice was directed thereafter, and it was for the first time said that pilot was chronically fatigued as a result of obstructive sleep apnea. Now, advice was for the first time they said that any heavy vehicular say transportation, be it plane, be it ship, that the pilot first have to clear the sleep study, so as to see that, because it is not only his risk, life at risk, it is so many people other getting affected by it. And there was basically overshoot while the pilot had a shoot over, and it overshot the landing mark, and 103 people, 23 people died. So we see accidents in and out. The importance is that the list can be as long as you wish to be, but the more important is that could they have been averted? A larger number could have been averted. Sleep is basically governed by the law of one third. That is, one third of our lives we spend in sleep. At any given time, one third part of the population has sleep disorders. There are more than 80 sleep disorders, and the greater chunk is being taken by insomnia, sleep disordered breathing, hypersomnias, narcolepsy, parasomnias, restless leg syndrome, and sleep-related movement disorders. So there's a huge amount of disease under the surface. What is visible, it is like an iceberg. Only a tip is visible. 9 by 10 parts, they are not visible. So there's a huge, huge amount of gap. Now, if anybody asked me that what is the, say, your adequacy of sleep, how would you grade it? So adequacy of sleep is a function of its duration, timing, and quality. So all these features, duration, timing, and quality. Duration means the number of hours, timing is the regularity, and quality is basically when the sleep distribution and sleep architecture is fine. So if any of these three limbs is not functioning correct, then no matter how long you sleep, you are not rested. Now, coming on to one of the major ones, that is sleep apnea. Mark Twain once said, "Do not go to sleep. So many people die there." I don't know why he wrote this, but this was not too very off the mark, because a large number of heart attacks occur in sleep, a larger number of strokes occur in sleep, and people do die there in their sleep. So it is basically a continuum from mild snoring to complete obstruction, which is there. And around 6 to 8% of the population has sleep apnea. So as far as pathophysiology of this is concerned, now the thing is our throat, which is basically the breathing is occurring through our nose. And there is a choking over here. If you've seen somebody snoring, it is like the mouth opens and you're trying to inhale or force your inhalation. So as a result, and then the tongue falls back and there's total choking over here and can occur hundreds of times in a single night. The maximum that I have recorded is 3 minutes and 11 seconds at a stretch. These are the patients who could have conked off during sleep. So I literally had to wake that patient up. So complications of untreated sleep apnea could be related to anything and everything from pregnancy, pre-eclamptic toxemia, premature births, strokes, depression, epilepsy, impotency, pediatrics, attention deficit disorder, sudden infant death syndrome, seizures, enuresis, cardiology, I think is hypertension, coronary artery disease, angina, arrhythmias, and in social format, 1/3 of the road and industrial accidents they occur because of sleep deprivation, could be because of any sleep disorder for that matter. And now the latest entrants are type 2 diabetes as well as obesity and chronic kidney disease. And last but not the least, death during sleep. So the thing is, way back in 1996 in Journal of Clinical Investigation, Professor Viren Summers in Rochester, Mayo, he demonstrated that there is a sharp rise of muscle sympathetic nerve activity with every apnea. And consequently, there is a rise in the systolic as well as the diastolic things. So this kind of hemodynamic variability would occur every now and then. So it is important that we have to be very, very careful. And say around 40 to 50% of the cases have congestive cardiac failure, has sleep apnea. And this was done in two different universities. One was in Melbourne by Matthew Norton et al., and one was with Zaba Hari in Stanford. And the thing is, if you look at the Holter's monitoring, I can't show you right now because of the limitation that I'm having today, that there is a cardiac rhythm problem. There are basically asystoles, there are prolonged kind of, say, heartbeats. There are periods of tachycardia and bradycardia. So these patients are basically treated as cases of cardiac rhythm disorders. And a larger number were used to be put on the cardiac pacemaker. But the thing is, I requested my colleagues that, the portions should be, say, separated between wakefulness and sleepiness. So that if the majority of the problems are occurring during sleep, then the trigger lies in sleep because of hypoxemia. And if that is corrected, then rhythm disorder will also be corrected. Now, coming on to the strokes, there are both the embolic and hemorrhagic strokes. They can occur because of sleep apnea and snoring. The thing is, the maximum amount of snoring occurs in this area, which is the area where bifurcation of the carotids occur, and the maximum atheromatous plaques. So if there is a very, very, say, sharp voice, or basically vibrations because of snoring, say a weaker kind of a plaque might just rupture and go into the brain and cause the embolic stroke. And I've already told in the slide that what Willem Chalmers did to find out that there is a systolic and diastolic rise. So wherever is the weakest, say, kind of a, say, artery, it will rupture during that period, causing hemorrhagic stroke. Now, as far as the kidney disease, chronic kidney disease is concerned, there's basically today the National Kidney Foundation USA says that early detection and effective treatment of sleep apnea prevents or slows down the progress of kidney disease and its failure. Then comes the obesity. A lot of people feel that snoring and sleep apnea is because of obesity. But let me correct them that even an underweight patient, a patient with retrognathia, micrognathia, can have severe kind of sleep apnea. And obesity is basically, it boils down to two hormones, that is the leptin and ghrelin. Leptin is a hormone which suppresses the appetite, and ghrelin which increases. And it is seen that patients who are sleep deprived because of either sleep apnea or any other reason, their ghrelin levels are, say, higher, and as a result, they feel more hungry and put on a lot of weight. So essentially, snoring and OSA and obesity, they are two sides of the same coin. Now comes the biggest part of the role of the diabetes. 50% of the type 2 diabetes people have obstructive sleep apnea. Among obese people, it rises to staggeringly high of 86%. OSA is independently associated with glucose intolerance and insulin resistance, and increasing severity of OSA is associated with poor glucose control. Contrarily, CPAP therapy or therapy for sleep apnea significantly improves the insulin sensitivity, and it improves the HbA1c levels of the patient. So, and as far as we physicians are concerned, actually I am dealing in everything, but classically we deal in CPAP or auto CPAP or BiPAP. That is basically positive airway pressure systems, which act as a pneumatic splint and does not allow the structures to collapse. And a requisite pressure is there for every patient, which could be separate. Today we have got a lot of automatic systems, but again, still titration is essential so we can fix in the range in which it should ply. So the thing is, there were studies which showed that there is a fall in oxygen saturation with sleep apnea. And when CPAP was used, there was no fall, no stoppage of breath, and the patient was much better. Then comes the surgical aspects, where the treatment and procedures of say is basically ENT people uses UP3. Adenotonsillectomy is the treatment of choice in children. Then injection snoroplasty is there. Somnoplasty is there. But again, the efficacy is somewhere around 35% of the cases, and the recurrence rate is high over a period of time. So when we have to choose our cases very, very carefully, and the thing is, sometimes we need both of the say ways of working in a particular case, especially if there are a lot of nasal polyps or if there are say the nasal area which is totally clogged. Then we first need to clear them of the polyps so that the air movement zone improves. Then comes the mandibular advancement appliances, which we are making and since 2002. So there were two kind of generally, which is boil and bite type and custom made. We believe more in custom made after taking the bite forward at the 75% of the maximum one, and we take an impression, filter in upper and the lower part of that, and it causes say the forward movement of the lower jaw leading on. But again, having said that, my last speaker was also telling that it's very important to say take care of the TM joint, because the thing is, if it is being used and not the benefit is coming, the TM joint, if once damaged, it takes a longer time to heal, because this is your mastication area as well. So we have to choose our cases correctly. And now the thing is, another important thing was a case that I wanted to show you, but since I do not have the access to the say computer right now, I think is one person can suffer from multiple sleep disorders at a given time, and if not treated, then there will be a problem. Here was a case of 35 years male, a software engineer, and with great academic record. Had a history of snoring, daytime sleepiness, uncomfortable feeling in legs, and daytime sleep attacks, multiple loss of jobs, wrecked married life, and lot of dreams during sleep. Patient had history of tendency of fall. He also had 4 jobs in the last 5 years, he had lost them, and there were 3 roadside accidents. He was apparently well till the age of 27 years, started feeling sleepy, and physician gave him an alprazolam so that this could help him. But that was a condition where we should not be using any kind of a sedative in a snorer till we prove or disprove whether the patient is having sleep apnea or not. So this thing is, when we did the sleep study of this patient, though it had been done twice early, the thing is, it showed very clearly that when we did a full polysomnography on this patient, the patient was suffering with 3 different sleep disorders. It was sleep apnea, because already CPAP had failed. He was suffering from restless leg syndrome and as well as narcolepsy. Now, the thing is that if we are not treating all the 3 things together, then the patient will not have the benefit what the patient required. The thing is, so, having a psychiatric treatment or antidepressants or everything, they may not be helpful because it will lead to increased amount of sleep apnea. And that is where we should be very careful. If we are having more than, say, one sleep disorder, we need to treat them all. And so we did that, and we used basically tryptoma for the treatment of tryptoma for the treatment of narcolepsy. Modalert was given for the daytime sleepiness. Rivotril was given for restless leg syndrome, and nasal CPAP was given. There was remarkable improvement, no daytime symptoms. Patient now lives in Chicago and is in touch with me. So it's very heartening to see that if you catch up the things correctly and do your study in a proper way, then you can get them. Sometimes we take a shortcut like 4 channels, type 4 type or type 3 type of a study, but we may lose a lot of data for the neurological inputs. So there are times at the first time one should do a polysomnography so that nothing is missed out. And once you know what is the case, then you can, if it is a pure sleep apnea case, then you can go with the type 2 or type 3 study as well. So multiple sleep disorders are not very uncommon. I have done more than 150 cases. In this case, he was suffering from 3 different sleep disorders, and unless we treat all of them together, the patient is not going to get the benefit. So, conclusion that ignorance about sleep is the worst sleep disorder of them all. We must not take symptoms of sleep lightly. Sleep disorders can easily be diagnosed and treated. So we have various pathways. What we require is the correct direction. Do we have some time? Hello? Hello?
So
Do
we
we
can
have
hear
some
you.
time? Do we have some time? Can anybody tell me? Is there some time left or should I stop it here itself?
Sir, you please continue speaking. We are all interested to hear you.
Okay.
It doesn't matter.
Now there is some things called the myths regarding sleep and sleep disorders, which are again very, very common, and we oversimplify the things. The first premise is that people feel that sleep is equal to rest. It might not be equal to rest. As I told, that there are 3 different things: the regularity, the timing, and the say sleep architecture. If any one of them is having a deficit, sleep may not be equal to rest. A lot of people are treating sleep medicine as sleep apnea, which is again wrong. Neither is sleep medicine insomnia. So the thing is, it is important for us to realize that what are we treating and how are we treating. A second myth is that a beer or a wine before bed helps you sleep. On the contrary, it can relax for some time, but it causes the REM rebound and nightmares can follow. And frequent alcohol can launch vicious cycle of taking alcohol regularly. The third is insomnia is characterized only by difficult falling asleep. There are 4 ways in which it can function. One is you are not sleepy at all. You're feeling sleepy but not able to sleep. You take a lot of time in the bed to sleep and you wake up frequently. And one is that delayed onset sleep followed by delayed onset wake up. So first we have to, when we take a history, we should know what are we looking at. And once we know that, and the study tells us, then we can do the treatment much more effectively because there is no drug which satisfies everything. So you have to pick up what is harming the patient, and accordingly we should treat. People used to think the sleep disorders are difficult to treat. They are rather easy to treat, diagnose and treat both ways, at home as well as through polysomnography in a hospital. A very important myth is that people believe, I have learned not to need as much sleep. They feel, मेरा इससे कम में गुजारा हो जाता. I can sleep as much as say 3 hours or 4 hours. But the fact remains, sleep needs are genetically determined and cannot be changed. Fact is, although performance of the tasks may improve somewhat with effort, the optimal performance and consistency of performance do not. Second is estimating your sleepiness. The myth is, I can tell how tired I am, and I know when I'm not functioning up to the par. But the fact is, studies have shown that sleepy people underestimate their level of sleepiness and overestimate their alertness. The sleepier you are, the less accurate you are, and your perception and degree of impairment is there. It will be important for you to understand that a person can go from wide awake to deep sleep in less than 10 seconds. And that is where majority of the roadside and industrial accidents, a snooze at the wheel might go for say all times. Now there are some funny and spooky things which are there. There are parasomnias like sleepwalking, sleep talking, sleep violence. Now, here are certain things which have been recorded in 2002. Well, this I'll skip. The person murdered his mother-in-law, whom he loved, in the year 2000. Has been the estimated 68 cases of homicide while sleepwalking, and they are not aware of it. So the thing is, there were 3 or 4 major cases which occurred, and 2 were acquitted and 1 was sentenced. And then there is basically nocturnal sleep disorders, cheating on diet. One is nocturnal sleep-related eating disorder, and second is night eating syndrome. They are 2 separate things. So in nocturnal sleep-related, the patient is not aware of what is happening, whereas in night eating syndrome, they are aware of it. Well, there was a case, again, it was in 2007, the teenager in Germany, it managed to climb out of the 4th floor of the window and had fallen. But incredibly, he did not suffer. So he did not only survive, he actually sustained relatively mild injury. Importance is that in a limp body, there is lesser amount of, say, injury than in a stiff body. Well, there was something which was again interesting in 2008, and it was recorded what we call as, say, drunk texting. So the person kind of thing is that in sleep, the patient picked up the internet, and while asleep, gave an invitation to a lot of people to come for the dinner. There is another thing which was, there's a person as a sleepwalker. This was published in the University of Pennsylvania School of Medicine. Rosenthal was a sleepwalker, and in the daytime he was a nurse, but in the night he would become a musician, and who would conduct an orchestra and vocalizing all the instruments as well, and would find himself in, say, places where he should not be, in jungle or somewhere around the home. The strange and thing is that he was a part-time maestro. Then there is a nurse called Hadwin, and the thing is, in the daytime he was a nurse, but in the night he becomes a gifted artist. And his videos are there of Hadwin in BBC, and the period lies between 20 to 90 minutes of fast strokes and very, very beautiful drawings. Whereas when he gets up, he says, I can't draw even a circle correctly. And then last but not the least, basically, it is a very expensive disorder. Sleep disorders are very expensive. Roadside industrial accidents, they in 2004, between 2000 to 2006, Adelaide and in Canada, Manitoba, and it was a multi-centric trial where more than 800,000 say sleep-related or sleep apnea-related motor vehicle collisions, and which costed about $16 billion and 1,400 important lives. Treating all the drivers would be just $4 billion and saving, $3.1 billion and saving around 1,000 important human lives as well. So the thing is, the fact is that the direct health costs of the sleep disorders, that is 146 million, are only 2% of the total cost of the disorders and their aftermaths. So I think it is a very, very expensive kind of a disorder which can totally be corrected and saved. So now the major concern is sleep is underrepresented on national health agendas despite the availability of a range of proven cost-effective interventions. Second is priority intervention should include public education, awareness raising, research, and continuing development of cost-effective prevention. And in around 2024, untreated sleep disorders and inadequately treated sleep disorders is one of the largest, deadliest, and the most costly problems. And most important is the ignorance, as I always said, is the major cause about sleep disorders. There's a late start to this discipline, so not many people are actually doing pure sleep medicine. And teaching about sleep is almost totally absent from the mainstream curriculum. The starting points would be that sleep is a basic human right, recognized or not. It is crucial to health, well-being, and social functioning. So today we are having a 24-hour society. Strategies for improving peak human performance must involve a sensible awareness of human limits. Systems and procedures must be designed to play up to the human strengths rather than weaken them up. And there's a persistent conflict between biological imperative for sleep and social demand for performance. This poses a fundamental question. What happens to the performance when the pressure for sleep is increasing? So sleep depth is like a lava, which is basically boiling inside to erupt. And William Dement, the founder president of American Sleep Disorders Association, wrote a beautiful quote that nearly half a century, a huge reservoir of knowledge about sleep, sleep deprivation, and sleep disorders has been building up behind a dam of pervasive ignorance. We do not know how many preventable tragedies are occurring right now, today, this instant. It is time either to lower down the floodgates or blow up the dam. So the thing is, if we start taking these things seriously, the challenge is that we must change the way society deals with sleep. The opportunity is the human race will be lifted to the new level of energy, health, and safety. And I'll end by the famous line from Sir Robert Frost. That is, the woods are lovely, dark, and deep, and I have some promises to keep, and miles to go before I sleep, and miles to go before I sleep. Thank you, ladies and gentlemen. And I'm sorry for being not able to show you the graphics, but whatever I could say, that was it. Thank you so much. If anybody has any questions, please, you can come up with that. Am I audible?
Yeah, you're audible, sir. Anybody who want to ask question, they can ask question to Dr. Sanjay Manchanda. As I introduced that he is the pioneer and he is the most experienced authority who is experienced in dealing with the sleep disorders. So anybody who want to ask question, they can ask question right away here only. They can unmute your microphone and ask question. So there is no question yet.
Either it was
Dr. Sanjay, stay with us for some time. Maybe Dr. Saurabh is in the queue. He would be presenting his presentation. So after that, maybe the question arises. They can ask questions simultaneously. If you have a time, you can stay with us.
I'll
Hello.
go right now and I'll try and come back.
Okay. Okay.
Okay.
So we are very thankful. I think committee of Ismcon 2024 is very thankful to Dr. Sanjay for joining us, even though the system is not working. So thanks to again Dr. Sanjay for joining us. With your permission, we are moving to our next speaker, Dr. Saurabh Das.
Am I audible?
Yeah, Dr. Saurabh, you are audible.
Okay, I think I have sent the
Yes,
PPT.
Dr.
Can you
Dr.
kindly
Sanjay,
run it for me?
Dr. Sanjay, we are moving to the next speaker.
Yeah, I'm seeing that.
Yeah, okay. Yeah. Yes, okay, thank you. So, Dr. Saurabh, let me introduce you first, and then if you want to add anything in your introduction, you can add before going into
No,
it.
no, it's all right. I don't care much about introduction to give.
Yes. No, I'm just, formally, no, I'm just formally introducing you. Just wait.
Sure, please go ahead.
Yeah. So Dr. Saurabh Das is the MD at DNB, ISM, IBSM, a senior consultant, psychiatrist and sleep medicine specialist working in Kolkata. He has international certifications in addiction medicine, ISAM, Canada, and sleep medicine, WSF, USA, and runs his own state-of-the-art sleep lab named Somnos Sleep Clinic. He has more than 25 international and national journal publications and is an honorary reviewer with journals like Schizophrenia Research, Brain Behavior Immunity, Psychoneuroendocrinology, Asian Journal of Psychiatry, Sleep and Vigilance Point of Care, Elsevier India, Annals of Thoracic Medicine, Journal of Neurology, Neurosurgery and Psychiatry, Indian Journal of Psychiatry, BMC case reports, and many others. He has also written a few chapters in a book by global publisher like Springer, Elsevier, etc. So this is the brief introduction from our side. Over to you, Dr. Saurav, to start your presentation. We have made your presentation live. I think it's visible to all.
Yes. Thank you so
As
much.
you guide
Firstly,
us,
for
we'll move to the next. As you're guiding, we'll keep on moving the slides.
sure. No problem.
Okay.
Okay, so thank you for inviting me, first of all. And actually, I'm not in my home or in my office. I'm in a different conference right now, so I'm using my mobile phone to do the presentation. So there may be some little bit of technical glitches, but I hope people should not mind that. So basically, my topic is sleep and cognition, the bidirectional relationship. That is basically, we know that cognition means the higher mental function, and cognition is something which separates us human beings from the other vertebrates or mammals. Okay, because we have this special ability to understand things, to think about things, and to decide and take judgments and everything. All these things fall under the domain of cognition. Now the point is, as Dr. Manchanda was saying so nicely just before me, that the kind of sleep deprivation has a huge burden on society, and it can cause a lot of different damages, both financially, socially, as well as personally, even legally sometimes. So those things are exactly correct. And how it is, how these things happen is because sleep can actually impair cognition. Now, sleep can impair cognition both in the short term as well as in the long term. Okay, so our presentation, we will try to cover all those things. I'll be dividing it into 4 parts. First part will be like the basics of sleep. Firstly, to understand how we understand sleep biologically. Then we'll go to the second part about how sleep impacts cognition, and we'll then go to the third part about how sleep affects the risk of cognitive degeneration or certain diseases like dementia, etc. And lastly, we'll talk about how cognitive degeneration affects sleep. So, with these basic structure, we move forward. Kindly show me the next slide, please. Yeah, thank you. And just keep clicking. Next slide. Okay, so yeah, thank you. So basically, we can see here there are a few graphs. Okay, so basically, we know that if you look in the just before the previous slide, yes. Now, if we look into the bottom left corner of the screen, we will see that there is uh, like homeostatic sleep drive, and there is a circadian wake drive. Okay, you can see these words written on the left side. So, and also you can see in the picture there is like a yellow bar and a gray bar, and which is marked by one red and one blue line. So these are basically nothing but the diurnal motions of our body's system which regulates the sleep. Basically, there are two separate systems. One is called the circadian system or the process C, and the other one is called the homeostatic system or the process S. Now these two processes work together in tandem to produce what we call as sleep. Now usually what happens in the homeostatic sleep drive, the sleep pressure is highest in the after evening in the night time, and similarly in the circadian sleep drive, it is also in the highest level in the night time, that is controlled by the hormone called melatonin. So now we have the sleep pressure, and we also have the high melatonin concentration in the night, and which causes us to fall asleep. And now when we fall asleep, the sleep is actually divided into different cycles of sleep. Okay, now each of these. Hello, am I audible?
You are audible, Dr. Saurabh.
Hello.
You are audible, Dr. Saurabh.
Yes, yes. Okay. Okay. So now each of these cycles are again subdivided into some stages. Like there is something called the N1 stage, which is the light, very just when the person falls into sleep. There's something called the N2 stage. So after N1 comes N2, this is also a part of the light sleep. Then there's something called the N3 stage, which is actually the slow wave sleep or deep sleep. And after that, we get something called as REM or rapid eye movement sleep. This is the type of sleep stage where we actually dream, and then again it goes back to 3 2 1 and like that. In between there can be certain moments of wakefulness or w or wake. So you can see in the graph on the right top corner of the slide that the same thing has been shown here, like from wakefulness gradually the person sleeps and the sleep gets deeper from 1 2 3. Actually this is actually an earlier image, like earlier we used to talk about stage 1 2 3 4. Now we have clubbed the stage 3 and 4 together into n3 or the n3 or the deep sleep. So you can see that after 1 and 2 comes the deep sleep, then again it goes back, and in between later on there comes REM, the gray horizontal bars on the top. So basically, as this thing moves forward, as the sleep cycle moves forward, you see there is more REM sleep and less slow wave sleep. And on the other hand, in the beginning of the sleep, there is more deep sleep or slow wave sleep and very less REM sleep. So this is normal sleep physiology. They are characterized by different kind of EEG waves. You can see the graph given below. Like for example, the deep sleep has is called delta waves, the frequency is zero point 0.5 to 3.5 or 4 hertz, like cycles per second. And then the N2 or N1, they usually have what we call as theta waves, with cycles of 4 to 8 hertz. Now, when we are having restful, like we are at rest, our eyes are closed, then we have something called as alpha sleep, whose frequency ranges from 8 to 13. And when our eyes are open and we are focusing on something, trying to concentrate, then we have something called as beta waves. Okay, its frequencies are around like more than 13 hertz. So this is the basics. Let's go to the next slide, please. Hello, kindly go to the next slide. Yeah, thank you. Now, when we talk about the process here, the circadian process, we can see that there are certain brain centers. I'll be very brief here. Like there's something called the wakefulness center, which is basically the tuberomammillary nucleus of our hypothalamus, which has neurons which secrete histamine. These are called histaminergic neurons. So you can see from the top left corner of the slide, sorry, the middle left corner side of the slide, that the histaminergic neurons proceed towards the cortex, or that is the cerebral cortex, where the histaminergic drive is there and histamine is getting released. And it also has another branch which goes to the VLPO or ventrolateral preoptic nucleus, which is actually the sleep center. So the wake center, the TMN nucleus, it inhibits the sleep center when the TMN is active, and conversely, the VLPO also has a system of inhibiting the wake center or TMN. So basically, there are two switches, like flip-flop switch. One is switched on, we are awake. The other is switched off, we are asleep. When we are switched on, the histaminergic system takes over. When it's switched off or we are asleep, then the VLPO system, which is GABAergic neurons, that takes over. Now, these two switches are manipulated by two other centers. One is the lateral hypothalamus area, which basically secretes something called orexin, and this orexin actually modulates the wakefulness. And on the other hand, there is another area called suprachiasmatic nucleus, which is again called as this is basically the master circadian rhythm regulator of our body. This suprachiasmatic nucleus secretes melatonin. Like basically a pineal gland secretes melatonin, but suprachiasmatic nucleus it starts the first impulse to start secretion of the melatonin. So this again modifies the wake center and the sleep center. So basically there are two primary centers, TMN nucleus as well as the VLPO, and there are two secondary centers which modulate the two primary centers and thereby causing us to fall asleep or stay awake. Now let's go to the next slide, please. Hello, next slide. Yes. So we can see here the sleep circuit. We can see that From VLPO, there are numerous GABAergic projections to different brain areas, which are related with arousal, which are related with cognition and arousal. And those areas are again modulated by other this is the GABAergic system of the brain. So GABA is secreted by at these systems, and it causes an inhibition of the cerebral cortex and causing sleep. Please go to the next slide. Next slide, please. Yes, thank you. Okay, so this is process S. This is basically the homeostatic sleep drive that I was talking about earlier. So what happens in that is that there are certain molecules called somnogens. One of the most important molecule in this segment is called adenosine. We have all heard the term adenosine. Now, adenosine concentration in the brain, it keeps on gradually increasing as the day progresses and as the day goes by. And it is something, basically, it induces sleepiness when it attaches to a correct to its proper appropriate receptor in the brain, in the hypothalamus. Okay. Now the problem is that this adenosine 2A receptors have also been identified on the this adenosine A2A receptors. They also attach with caffeine molecule. So basically, what caffeine does, it competitively inhibits or displaces the adenosine from the adenosine A2A receptors, thereby inhibiting the sleep drive. Okay, now the problem is that coffee half life is the caffeine half life is around 6 hours. So if you take a cup of coffee at 12 in the afternoon, then you will have around half cup of coffee left in your system by evening 6 p.m. And you will have 1/4 cup of coffee left in your system at 12 a.m. in the night. So you can understand how it works. It basically decreases the sleep drive, homeostatic sleep drive, by displacing the adenosine. There are certain other molecules like, for example, interleukin 1, human necrosis factor TNF. These are inflammatory markers of the body or inflammatory cytokines, which again gets attached to certain areas in the midbrain, and that also act as somnogens, and they can induce sleep. We all know that when we are feverish or when we are sick, we tend to be more sleepy than usual, right? So this is how it works. So and now this process S and the other process C I described earlier, they work together in tandem to induce sleep in the human body, in the human brain. Next slide, please. Thank you. Now we also have something called the REM switch. It looks a bit complicated. I will not go very deep into it right now because I have lots more to talk about. So basically, what happens is, just like the wake and sleep switch, there is another switch called the REM switch, which again is modulated by numerous other brain centers, and it's a very complex interplay of the different systems: the serotonergic system, the histaminergic system, the dopaminergic system, the noradrenergic system. So all those things, they work like some stimulate, some inhibit the centers called ventral periaqueductal gray matter area. Okay, and the lateral peduncular tegmental nucleus. So lateral pontine tegmentum. So these two areas, and on the other hand, there is a precuneus and these superolateral dorsal tegmental nuclei. So these two areas are acting in opposition with one another, which are again modulated by numerous other neurotransmitter to induce REM, that is the dream when we dream that part of the sleep, or to inhibit it. So there is this REM switch as well. Let's go to the next slide, please. Okay, so now what happens is that during the process is, like when you're sleeping, there is some very important thing happens, which is called synaptic homeostasis. Like for example, we can think that we go through each day, we have so many experiences, we have so many sensations on our various sense organs, we do so much things, we listen to so many things, but how much of them actually we remember? After 5 days or 7 days or 5 years, like that, right? We don't remember usually most of the things, because there are certain very specific things that we remember, maybe even for a lifetime, but most of the day-to-day things we do not remember. Now this thing happens with a process called synaptic homeostasis. That is basically when during the sleep, particularly during the deep sleep and the REM sleep, all the information that has been collected throughout the day in the brain, it undergoes a review. Okay, and the areas which, or the like the information which is not needed or which is not relevant or which is very mundane, they gets wiped out by the process of synaptic remodeling or synaptic homeostasis. And the ones which are important, which are mostly emotional and relevant to us, okay, those things get stored and kept in various, again, synaptic remodulation, which is called as long term potentiation. Also, this is one thing that happens, like the unnecessary garbage gets discarded, the important relevant information gets stored. And another very important thing happens is that is kind of like it works like a zip drive, like suppose you have 5 hours of relevant information in the 24 hours daytime. So those 5 hours will be compressed or zipped into a 5-minute file in your brain by modulating certain synaptic structures in the different parts of the cerebral cortex. So this is what is called a synaptic homeostasis, a very interesting concept. And this very important thing happens when we are sleeping, particularly during the REM sleep and the slow wave sleep. Next slide, please. Yes, please keep forwarding and move to the next one. Yes. Now let's, with this basic background about how sleep is, we have understood that sleep is controlled by certain neuronal centers in the brain, and how that helps us fall asleep, and how it induces REM sleep and phases of REM sleep, and how what slow wave sleep is, and why these are important for cognition, because it helps in storing memory. Helps in storing memory, and of course, memories are very important for longitudinal decision making as well, because what we learn, that shapes our future behavior, right? So if the learning is not adequate, it's not appropriate, then we keep taking the wrong decisions, and the cognition gets impacted. So this is the very basics of why sleep is important for cognition. Now let's come to the second part, that is how sleep impacts cognition. Now this is a slide which just a second. Yeah. So basically, you can see the few graphs on the right side of the page, which basically shows something which is very important. These are like there were certain cognitive tests which were being done. For example, psychomotor vigilance test, okay, digital symbol substitution task, and also there are activation tasks. So there are various cognitive tasks that were being done in certain subjects who had different days of sleep restriction. Okay, like you can see in the x-axis of the graph that there is a number of days of sleep restriction, like baseline, and then there is 2 days, 4 days, 6 days, 8 days, 10 days, 12 days, and 14 days. Like it was done with sleep restriction of up to 14 days, and they had plotted the scores of these different tests. Now you can see that with the number of sleep restriction that is there, the more sleep restricted a person becomes, the cognitive function declines. Okay, then the cognitive function keeps on declining in most of these tasks. Now there are certain graphs which are growing upward. Now those are actually reverse graphs. That is, like the higher the graph is, that means the higher number of errors, and your cognition is actually lesser. Okay, so that is how it is happening. So let's move on to the next slide, please. Next slide, please. Yeah. So let's move on to another study, which is a very interesting study and very relevant to us doctors and physicians here. The effect of reducing interns' work hours on serious medical errors in intensive care units. Okay, this was published in the New England Journal of Medicine in 2004. Okay, it's a very relevant study. Please go. Basically, what it did is that medical interns working in the intensive care unit on a traditional schedule consisting of extended shifts of greater than 24 hours made 36% more serious medical errors than interns on a modified schedule with shorter sleep shifts and less total hours per week. Let's go click the next slide, this page, please. Let's have a look at the graphs. Hello. Next slide. Yes, and the other, yes, thank you. So now we can see here in this graph, we can see there are two shifts. The top one is having like the traditional schedule, and the second graph B is having the intervention schedule. So how does the traditional schedule works? It works like the interns were given longer shifts, like it starts on Thursday, ends on Friday, and then there's a gap of 1 day in between, and then again starts on Sunday and ends on Monday. So basically 24-hour shifts, and in between there are 24 to 30 hours gap. On the other hand, we had the other intervention schedule where there were around less work hours, like work hours restricted to 8 hours or 12 hours, and sufficient gap in between. And they found out that the serious medical errors, and in the terms of medication, procedural diagnostic, and others, were significantly higher in those people who are having a longer shift and longer working hours and less sleep time compared to those who have a regular shift. Because if your shift stretches beyond 24 hours, your entire sleep wake cycle gets disrupted. And on the days that you are off, you don't spend it sleeping properly, you spend it doing other household activities that you are supposed to do earlier. So please click on the slide again. Yes, so we can see that the serious medical errors were around they were around 36% more compared to the interventional schedule. And the medical errors were highest the mistakes were mostly made in the field of writing medications. They were making incorrect prescriptions and not writing the correct doses or the correct names of the medications. And also it was incorrect in terms of the diagnostic dilemmas faced by the interns and the diagnostic things that they were made. But on the other hand, they did not show much of a difference or discrepancy in the procedural interventions. For example, a person is doing, say, nasogastric intubation, or the person is doing an IV cannula. In those cases, there is not much of an error. Probably it is because when we are trying to do some serious procedures or this kind of procedures, our brain goes on a hyperactive mode. Our brain becomes very alert and it tries to take up all the cognitive reserve that the brain has to perform that particular function, thereby counteracting the effect of sleepiness. Now this thing is good for a short period of time, but for a long period of time, if the person is doing this kind of schedule for years together, then definitely there has to be some cognitive mistakes in procedures as well. Now let's go to the next slide, please. Yes. So yeah, next slide. Yes, thank you. So we can see here that uh, the effect of reducing interns' weekly work hours on sleep and attentional failures. You can see that there are two graphs here on the left side of the screen. The one in the deep bluish is the traditional schedule, and the light grayish is the interventional schedule. The interventional schedule had an additional 6 hours of sleep per week. Okay. Now let's please click the slide again. Yes. So we can see that what they had found out is that while the interns were doing their work, there were episodes of micro sleep in their work hours. Since their traditional schedule stretched sometimes up to or even beyond 24 hours, they were having episodes of micro sleep when the person was actually working. Okay, and the rates of attentional failure was quite higher in the traditional schedule than in the interventional schedule, and the ratio was like 0.33 per hour or 2.6 attentional failures per intern overnight. Okay. So, and it was less than half that during the corresponding times on the traditional schedule. So, like it was like 0.69 per hour. So, those interns who are having a modified schedule or intervention schedule, they were making much lesser mistakes. And in fact, less than half of the mistakes that the intern was doing when on traditional schedules of 24 hours. Please go on to the next slide, please. Okay, so now here we talk about different kind of experiments that were done, like overnight improvement in visual discrimination tasks found only when this time included sleep. That is correlated both with the amount of slow wave sleep and the REM sleeps. For example, in the visual discrimination task, there are certain like for example object sorting, where if you discriminate between different shapes or different objects or different sizes, that thing is performed better when there is a sleep in between. For example, today you do the task and tomorrow you do the testing. It will improve only if there in the intervening period the person had slept. For example, if a person does the test today, tonight he does not sleep, tomorrow he again does the test, there will be no improvement, there can be some worsening instead. But if the person does the test tonight, today, sleeps tonight, wakes up tomorrow and does the test, then there is definite improvement in the visual discrimination task. Also, 1 to 6 additional nights of sleep after training resulted in significantly more improvement than seen after only one night. And not only it is improving after sleep, the improvement keeps on improving after multiple nights of sleep. Okay, so when we do this use this common parlance of let's sleep over it, let's think and sleep over it, so that is actually true in a scientific sense, and it actually means that you are trying to improve your cognitive capacity of thinking and judging and making rational decisions when you are having proper sleep. Now, subjects who were deprived of sleep the night following training did not improve on the visual discrimination task even after 2 nights of recovery sleep. Now, this is very important that if you are missing one night of sleep, even if you sleep 2 nights afterwards, do not make the recovery that is lost in the first night of sleep. Next slide, please. So these are other various cognitive things. I'll be talking about them very quickly because each of these are very elaborate experiments, and if I talk about each of these in length, then I'll be missing out on the other parts of the presentation as I have to maintain the time as well. So this is basically some other tests like 5 elements sequences of finger to thumb opposition tests. They also demonstrated no further significant improvement when retested after 12 hours of daytime wakefulness. But when retested after 12 hours that contained a night of sleep, the subjects improved in sleep speed by 20%. Okay, similarly, there are different kinds of experiments that are done, and when tested after 8 hours of training, the direction error was significantly reduced in a group retested after an 8-hour night of sleep compared to the group retested only after 8 hours of daytime wakefulness. So you can see all the experiments talk about the same point that the speed of mental processing. This particular slide is about speed of mental processing that actually gets improved when the person is having a sleep in between two successive attempts of the test. Please go on the next slide. Now, not only the speed of attention as well as the visual discrimination, but also the memory or declarative memory, where we try to memorize in pairs of words. Okay, say the two word, each word is given in a pair to the subject and asked and to recall what these pairs were by giving the cue. For example, the person is being told two words like hat and coat, and similarly they are given a list of say 20 or 30 pairs, and then after some time they are asked to recall the other part of the pair by giving one part. For example, the person giving hat and coat, two pairs of word, one pair of word initially, and then the person is asked to about the other part of the pair by saying hat. Then the subject test subject has to say coat, because then it completes the two part of the word pair. So in this particular task, which actually tests declarative memory or higher mental function, it has found that recalled word pairs were better after sleeping during just the first half of a night or sleep than the second half. So the benefits of sleep was also seen on the word pair task in subjects who took daytime naps that contained only non-REM sleep when compared to subjects who stayed awake between training. So it shows that the declarative memory works is more relevant in cases of slow wave sleep or non-REM sleep. The declarative memory works better. Let's go to the next slide, please. Now there is sleep dependent development of insight. So also there are studies done which showed that the person's insight about various factors, including our own selves, is altered or disturbed if there is a sleep deprivation, and the subjects who slept properly had more capacity of gaining insight compared to others who were kept awake. Let's move on to the next slide, please. So there are various kind of cognitive tests in which deterioration of performance has been reported, and this is just a review kind of a thing where you can see that all these articles and all this research was done on different aspects of human cognition and sleep deprivation. Please go on to the next slide. To the next slide, please. Yes. Now let's come to an interesting part that cognitive modulation during sleep. For example, when a person is sleeping, can we modify the person's environment in such a way that his cognition improves? Okay, so there were a few experiments done where some learning tests were given, and it has been seen that like giving certain orders while the person is having a slow wave sleep, or giving certain sounds when the person is having REM sleep, they actually have improved learning about some certain cognitive tasks. For example, the order like the card pair associations. Okay, there was some cognitive test which is done known as card pair association. It was found to be much better when the person was having given a certain order while the person is having slow wave sleep. Okay, so let's go on to the next slide, please. And this is another one which shows that the stimulating slow oscillations during sleep enhances memory. like they were again given word pair tasks and finger sequence tapping, and they had given certain electrical stimulation of slow oscillations. Like they were given actually transcranial direct current stimulation at 0.75 hertz during the ensuing sleep, and they compared to sham. They found that after giving TDCS, and while giving TDCS during sleep, the person actually remembered more word pairs after this particular stimuli. So if we give TDCS in the certain areas of the brain once the person has fallen asleep, then there is higher chances of cognitive functioning in the person the next morning. And this is actually used widely in the West by various, you'll see articles in newspaper that CEOs of companies zapping their brains at night. So basically, this is nothing but this particular thing that they're doing. Please go on to the next slide. Now let's come to the third part, like how sleep affects the risk of cognitive decline. Now it has been seen that the lesser the person sleeps, the higher the cognitive decline happens. And this particular data was published in the Journal of Medical Association. It's a very big journal, JAMA Network Association, and it analyzed more than 20,000 participants. Okay, and please go on the next slide, please. And more than 20,000 participants were analyzed and assessed, and they found out that those who are sleeping for less than 6 hours each night, or those who are sleeping for more than 10 hours each night, each of them had a higher rate of cognitive decline and disorders like dementia and mild cognitive impairment compared to those people who are sleeping between 7 to 9 hours of sleep. So basically, not only less sleep but also more sleep does more cognitive decline to the human being. Please go on to the next slide. This is another article from the Nature publication group, which associated the sleep duration in the middle and old age with the incidence of dementia. And they found out that sleep association of sleep duration at the age of 50, 60, and 70, and the incident dementia over a mean follow-up of 24 years respectively. They found out that lowest dementia incidence per 1,000 person years were observed among people who slept 7 hours per night. Shorter sleep duration was associated with the highest incidence of dementia at all ages, and there was no clear evidence of an association between uh, between evidence association between long sleep duration and incident dementia. So regarding the development of dementia, it says that the lowest dementia incidence was around 1,000. It was those who were sleeping 7 hours per night, they had the least number of dementia. Those who were sleeping less, they had a higher amount of dementia. But those who were sleeping more than 10 hours, there was no clear-cut association in this particular study. Let's go on to the next slide, please. Now, after the sleep duration, somebody thought of doing this research about the timing of sleep and the risk of dementia, like how much when you are sleeping and what kind of risk of dementia that you're getting. So they found out that those with bedtime before 9 p.m. were 2 times more likely to develop dementia compared to those going to bed between 9 and 11 p.m. So basically, later bedtime after 11 p.m. showed the opposite, but had a non-significant association with dementia risk. So basically, again, it showed a very interesting finding is that going to sleep very early or going to sleep very late causes more damage to your brain and increases the risk of dementia. But on the other hand, sleeping on time between like 9 to 11 p.m. it decreases the risk of dementia significantly. And there is more risk by going to bed early than going to the bed late. Let's please change the slide. Thank you. It is the same thing being represented graphically, and it has showed that the just what I had just now said, that you can see the blue graph there, and before 9 p.m. has the highest risk of dementia. The green line is after 11. Sorry, the green line is 9 to 11 p.m. and after 11 p.m. is the yellow line. So it is not significant. The later sleep is not associated directly, but there is a significant difference between going to bed time of before 9 p.m. and after 11 p.m. Please go on the next slide. Thank you. So now this is again another review article which systematically reviews and meta-analyzes the sleep problems and risk of all-cause cognitive decline or dementia. And you can see that it analyzed all these many studies. You can see on the forest plot diagram here, and you can see that most of the studies they have a very good effect size. Like you can see those of you who are those who know to how to decode a forest plot will very easily understand that this rectangular boxes in the right side of the slide, this is basically the mean effect size, and the bluish line that is extending from the left to the right below those on both sides of that particular box indicates that whether the thing becomes significant or not. Now those who are those you can see that there are many studies which where the line is not touching the central red line. The central red line is basically is a no effect size. Like if the blue line touches the red line, then that study shows there is no significant effect. Okay, so let's move on to the next slide, please. The next slide. No, the previous one. Yes, like now they also said that these four insomnia components are associated with 7 to 16% of increased risk of cognitive disorders, and those four insomnia components were daytime dysfunction, sleep inefficiency, sleep fragmentation, and increased sleep latency. Like they have seen that those who take more time to fall asleep, or in those the sleep fragmentation is higher, multiple times they wake up, or those who sleep efficiency is less, like the total amount of bedtime is much higher than the total amount of sleep time, and those who have daytime dysfunction due to these sleep problems, these four components were associated with a higher risk of cognitive decline and dementia. Please go on to the next slide. Next. Yes. So how does the sleep problems increase the risk of cognitive decline? It is uh, basically it shows that insomnia causes sleep deprivation. It decreases slow wave sleep, it decreases REM sleep, increases awake time. It reduces the glial clearance, and it also sometimes obstructive sleep apnea or other sleep disorders can also be coexistent, and it can cause intermittent hypoxia. And all these processes together increase neuroinflammation and oxidative stress, which damages the endothelial damage, makes the endothelium damaged and blood-brain barrier dysfunction, and it further decreases the A beta 42 clearance, and thereby increasing the A beta 42 and increased tau protein, which directly causes Alzheimer's disease. And on the other hand, having OSA and other intermittent hypoxic illnesses, which increase oxidative stress, it causes various metabolic, cardiovascular, or cerebrovascular compromise, which causes vascular dementia. So that is how sleep problems increases the risk of cognitive decline. Now, the last part of the presentation, how cognitive degeneration affects sleep. So we know that when a person is having cognitive degeneration, for example, having dementia, they have various kinds of different sleep disorders or diagnosable sleep disorders. Okay, so this slide gives just an overview about different kinds of uh, dementia subtypes. Now let's go to the next slide, please. Next. Yes. So no, the earlier one, please. Yes, so basically this particular slide talks about the sleep-related symptoms and major changes in sleep architecture associated with dementia symptoms. For example, we have seen that if there is in Alzheimer's dementia, 25 to 50% have associated sleep problems. In diffuse Lewy dementia, up to 85% have sleep problems. In pervasive development, in Parkinson's disorder and dementia, there is 60 to 90% have sleep problems. And what are those sleep problems? They are basically in the terms of irregular sleep-wake cycle, sundowning, possibility of more obstructive sleep apnea, REM behavior disorder, hypersomnia, due to changes in lateral hypothalamus. It also can cause restless leg syndrome or periodic limb movement disorder. It can cause nocturnal stridor, autonomic dysregulation. It can cause OSA, like obstructive sleep apnea, is also more common in patients of dementia, mostly because of decreased muscle tone of the upper pharyngeal airway. Let's go to the next slide, please. Now, coming to specific sleep-related movement disorders, there are certain disorders called restless leg syndrome or Willis-Eggbom disease, which refers to an overwhelming urge to move the legs, and it is usually associated with unpleasant sensations. It is worse at rest and at night, and is relieved by movement. So it has been seen that it is mostly present around 2 to 11% across different studies. Please go to the next slide. So this is how in polysomnography it looks like. You can see in the lower part of the slide there is some brown square and brown rectangle, which is encompassing fluctuation of this is EMG fluctuation, and you can see that this is the movement of the anterior tibialis muscle, which is recorded on the EMG of this person who was having uh, restless leg symptom or Yeah, RLS or PLMD. Go to the next slide, please. Skip this slide. I was trying to show a video of the person having how it happens in the movement, but videos I think will not. Okay, it's working. You can see how the movement of the legs, like there is extension of the big toe and the fanning of the other fingers of the leg. See, you can see the fanning, and this is exact the movement which gives rise to the graphs I had shown earlier, and this is the PLMD that is associated with dementia patients. This is an elderly patient, more than 65 years of age, having PLMD with my cognitive decline. Let's go to the next slide, please. Okay, so parasomnia is something which again Dr. Manchandra was discussing about earlier, which is characterized with the loss of normal skeletal muscle in REM sleep with prominent motor activity accompanying dreams. So basically, it's dream enactment and overwhelmingly a disorder affecting older men, many of whom eventually develop neurodegenerative disorders. Let's go to the next slide, please. This is very common in patients with parasomnia is very common in patients of cognitive decline, particularly those who have alpha synucleinopathy. For example, Parkinson's disease, multiple system atrophy, dementia with Lewy body disease, and pure autonomic failure. So this may be the first manifestation RBD and may precede these neurodegenerative disorders by more than many decades, sometimes 1 or 2 decades also. Okay, and let's go to the next slide, please. Let's go to the next slide. This is the neurobiology of how this RBD happens. I'll skip this today due to paucity of time. Please go to the next slide. Next slide. Next. Next. Yes. Okay. I think it will move. Okay. This is a patient of RBD. You can, if the video runs, you can see how violent the movement is. Like this person is actually dreaming about something, about some fight or argument with someone, and he is shouting and cursing and becoming very aggressive and violent while the person is sleeping. This is basically there is a disconnection between our cognition and our skeletal system, musculoskeletal system, normally when we are sleeping, but in the REM sleep, so we do not remember the dreams. But in cases of RBD, this disconnection gets lost, and whatever we are dreaming and how our brain is functioning, the cognition gets transferred to the musculoskeletal system, so thereby we enact our dreams. Okay, this is called RBD or REM behavior disorder, a hallmark of neurodegenerative disorders like alpha 1 synucleinopathy diseases. Okay, okay. Please go to the next slide. The circadian rhythm sleep wake disorders are very common. Like it can be delayed sleep phase, it can be advanced sleep phase, it can be regular sleep wake, non 24-hour sleep wake rhythm disorder, shift work, jet lag, circadian rhythm sleep wake disorder, not otherwise specified. Next slide, please. Next. So basically, the first four are okay. So basically, the first four are when the synchronization between the biological clock of the body does not work in tandem with the environment. Okay, so that is more common in the elderly degenerative neurocognitive disorders. Circadian rhythm disorders, delayed sleep, advanced sleep phase is actually more common in late adulthood. Non-24 irregular sleep wake rhythm is also more common. It is mostly seen in neurodegenerative disorders, post-age injury, etc. Let's go to the next slide. Uh, yeah, we can see that how these different types of disorders are. For example, typical sleep phase, you can see the top bar. The second one is advanced sleep phase when the people are sleeping early at before 8 p.m. and waking up early at around 4 a.m. and thinking that I haven't slept enough. The other one is the delayed sleep phase when people are sleeping late in the night in the early morning and waking up in the middle of the daytime. Irregular sleep wake pattern is when there are no fixed pattern of sleep and wake and it happens throughout the day. And all this is very common in elderly dementia patients. They spend most of the time in their beds and sometimes sleeping and dozing off, then again walking around a bit, and then it goes on through the day and night. Okay, let's go to the next slide, please. Next slide. Yes. So this is all, and thank you so much for your time and patience. I hope I have been able to give this very simple message that sleep and cognition are grossly interrelated, and disruption of one leads to disruption of the other. Thank you so much.
Anyone want to ask any question from Dr. Saurav? Thanks, Dr. Saurav, for a very elaborate and very enlightening presentation.
Yes.
Anyone
Thank
want
you.
to ask question to Dr. Saurabh? Dr. Saurabh is a psychiatrist and he is working for long sleep domain. So it's a privilege that he's with us, and anybody want to ask any question, medical question to Dr. Saurabh, please available. You can call your query there. I think for Dr. Saurabh, there is no any question. I think it's a
Yeah.
very explanatory. So if anybody have any question, I'll get back
Sure,
to
sure.
you
They
with
can get
your
back to me later. Sure, sure.
WhatsApp or email. Yeah.
Sure, sure.
So if you
Thank you
have a
so much.
time with us, you can stay with us, be connected.
No,
With
actually,
your
I have
permission,
to.
should we move to our next speaker?
Yes, yes, please, please, please. Thank
Yeah. So our next speaker is Dr. Gopal Rawal. Dr. Gop Yeah, Dr. Gopal.
Yeah,
You are
yeah. Shall I?
Yeah. So before we go ahead, let me introduce you. I have a brief introduction, and if you want to add anything, you can add before starting your presentation. Dr. Gopal Rawal is from Ahmedabad. He is MBBS, DNB in respiratory medicine, DT, CD, MNAMS, FICCM, FCCS, and EDRM and IVMS. He is presently consultant pulmonologist, critical care and sleep disorder specialist. His affiliation, he's associated with Shilp Chest Disease Center, Ahmedabad, where he's the managing director. He's associated with Sterling Hospital, Ahmedabad, Avron Hospital, Ahmedabad. He is a teacher for a DNB in critical care medicine as an examiner of critical care medicine courses. He is chairman of ISCCM Ahmedabad, and he's governing council member of International Sleep Disorder Association. His area of interest is mechanical ventilation, pulmocritical care, nephrocritical care, trauma and obstetric critical care, fluid therapy, and acid-base balance. He has many publications, many chapters in and update books and manuals. So if you want to add anything, Dr. Saurabh, I missed, you can add on and you can start your presentation.
Yeah. Thank you.
Your screen is visible, but yet slides is yet to visible.
Yeah,
Slides
is
are
it
not
visible?
yet.
Light is visible?
No, you haven't, opened it. You have made Ismcon 2024, but you have not opened it. Could you please open it once?
Yeah, it's open. Now it's moving.
No, it's not moving here.
Okay, I just stop share.
Can you do one thing, Doctor? Yeah, can
Yeah.
you do, Dr. Gopal? Can you stop sharing and then re-sharing again? Yeah.
Yeah. Now, is it visible?
Yes, it's visible. Yeah, it's visible. Can you make it a slide show?
Yeah,
possible?
just I will do it. And just let me know. Now,
Yes, it is on slide share. Yeah.
okay, fine.
Thanks, Dr. Gopal, for giving sparing your precious time.
First of all, thanks.
You are audible in your slides, sir.
Yeah, thank you, Dr. Nurul Anwar, Dr. Anshu Sahu, and Dr. Irfanullah for inviting me this International Sleep Medicine Conference 2024. I am very pleasured to be a part of as a faculty. And also just one thing, I am also doing PhD in sleep medicine also. It's my studies going on. So hopeful that in the next 1 or 2 years, I will complete the PhD in sleep medicine. So first of all, just I will tell that I will wish all of my friends and seniors and students that World Sleep Day just 2 days apart is that sleep equity. This time the slogan is sleep equity in the health growth. That is an important message. So with that, I'm going to start. Most of time that we think that the obstructive sleep apnea, the only treatment is CPAP. So this is first 2 slide is just propose the pathophysiological mechanism and consequences of the obstructive sleep apnea. As we know all, that the apnea, hypopnea that leads to sleep fragmentation, hypoxemia, and negative intrathoracic pressures, which leads to sympathetic surge, hemodynamic instability, oxidative stress, endothelial dysfunction, inflammation, hypercoagulability, and endocrine dysfunction, which leads to sleepiness, neurocognitive effects, cardiovascular, and endocrinopathy. So all of that sleep medicine, obstructive sleep apnea is related, not pertaining to any particular specialities, mainly the involving the ENT people, pulmonologists, dentists, psychiatrists, all kind of specialists. They should know about the presentation of sleep disorders and particularly the obstructive sleep apnea. So effective diagnostic and treatment strategies are needed to minimize the negative health impacts and to maximize the cost effectiveness of the things. So what are the general approach of the obstructive sleep apnea? So approach should be it is a chronic disease that requires the long-term multidisciplinary management with numerous questions already have been raised. So who suffers from the clinical significance OSA, then who should be treated, and what is the optimal therapy of the OSA, and how we can identify the responders versus non-responders. And the main goal of the therapy is to resolve the signs and symptoms of the obstructive sleep apnea, to improve the sleep quality, normalize the apnea hypopnea index and oxyhemoglobin desaturation, and maintaining the oxygen saturation level. And the potential benefits of the successful treatment is clinical improvement. As we all want that the clinical improvement should be there, less symptoms should be there, reduce the healthcare utilization and the cost, and the last is decrease the cardiovascular morbidity and mortality. So this is obstructive sleep apnea syndrome and its management. That is a practice guidelines, as we all know, that depends on the apnea hypopnea index that is less than 5. And if you have to reduce the primary snoring, because all snorers are not to be a OSA, so weight reduction, the behavioral intervention. Then if the person having AHI between 5 to 15, the presence of symptoms and cardiovascular morbidity, it should be treated with the CPAP or oral appliance or positional therapy. And if the AHI is more than 15, then it is obviously treated with CPAP and the oral appliance. So why should we offer the therapy beyond CPAP? We all know that CPAP is the gold standard treatment for the obstructive sleep apnea, but why we should think, and we all know that for last few years that the obstructive sleep apnea phenotypes and endotypes come in the picture. So different patient with the OSA having different phenotypes, then the patient's different orofacial anatomy, then different upper airway architectures and different pharyngeal pathophysiology. Because of that, we have to think that this patient may need other than the CPAP therapy, and we can diagnose that kind of patients and apply the proper treatment of that. So this is one paper that published in 2018 in American Journal of Critical Care Medicine. That's a phenotyping pharyngeal pathophysiology using the polysomnography in patient with the obstructive sleep apnea, and find it out how much the collapsibility, upper airway collapsibility is there. What about the loop gain, high loop gain, low loop gain? Then what is the patient's arousal threshold and the muscle compensation? On that basis, the treatment should be tailored in that form. So what can be offered to the patient for OSA? When the patient comes up of obstructive sleep apnea, and what you can offer that? Obviously, we know that behavioral modifications, positional therapy, then the dental and oral device, the weight loss, bariatric surgery, pharmacotherapy, though we know that there is no affecting any drug specific targeted for the sleep apnea, but we can give something that which helps to reduce the AHI. Then the airway modulations nowadays, hypoglossal nerve stimulation, at last the surgery. So we'll go in that detailed way. So first we all know about the behavioral. What is the sleep hygiene? We all know that's a restricted active time in the bed, use bedroom only for the sleep, then avoid to watch television, using mobile nowadays, laptops in the bedroom, reduction in number of teas and consumption of the coffee, and it should be at least 4 to 6 hours prior to go to the bed, avoid alcohol consumption or any CNS depression medications, to use bright light to get off from the bed, strict waking time, meditations and mindfulness, minimize the use of sedatives and weight loss. We all know that these kind of things helps, but unfortunately, the long-term success is poorly documented in the studies. So these are the variable option of the positional therapy, as we all know that tennis ball and the things. So recently that the sophisticated vibratory positional device that is helped to develop the study, its efficacy and better for the positional obstructive sleep apnea. It is not useful for all kind of, but particularly the patient having more of supine position related obstructive sleep apnea. You can, and patient is not willing for the CPAP, you can try this positional therapy. So uses of positional therapy in adults with obstructive sleep apnea. The study is published, and they conclude that in the short term positional therapy using tennis ball technique can easily method to treat most of patients with positional OSA. That also helps to reduce the AHI, but unfortunately the long-term compliance is low and close monitoring of such patient with positional therapy is required and the compliance is necessary. The role of weight management in the treatment of adult obstructive sleep apnea, that is specific advice about the what kind of diet as a part of as a comprehensive weight loss intervention. So key aspect is option for doing so, that including the how much the calorie should be given, then the calorie intake should be reduced by 500 to 1000 kilocalorie per day. Then it should not be a specific dietary composition like low fat, low carbohydrate and high protein proven to be more successful for the weight loss. Then specific advice for exercise and physical activity as a part weight loss intervention, like increase the aerobic activity, brisk walking for more than 150 minutes per week, avoid ambulatory convenience. Generally, we are using the elevators, so try to avoid that. Tailor activity to patient preference to maximize the adherence, and in long term, increase physical activity to 200 to 300 minutes per walk to minimize the weight regain. And this is a study comparing between the obstructive sleep apnea syndrome and the measure that physical activity and exercise training intervention. So systemic review and meta-analysis suggesting that no doubt it helps to reduce the AHI and excessive sleepiness. So these are the exercise training physical, like rostral fluids. It leads to rostral fluid shifting of the fluid. Then upper airway function also improve, pharyngeal collapsibility is reduced, body composition is changed. Also helps to relieve the comorbidities and ultimately help in the obstructive sleep apnea. Then one new thing since coming that is a myofunctional therapy. It is a new approach towards the non-CPAP therapy, that's training the movement, strength, endurance, neuromuscular activation of the upper airway, pharyngeal and tongue muscles to facilitate the that state that in which the snoring and OSA should be reduced in a sleep. So this is the pulmonary rehabilitation kind of things which helps to reduce the OSA symptoms. But it is the European Respiratory Societies that recommended it has a very low level of evidence that RCT is showing. So it should not be considered when the CPAP therapy is available. However, it may be considered if there is no other treatment can be offered to that patient. So myofunctional therapy is usually conjoint therapy. Then how does an oral device works? So most of time the snoring and obstructive sleep apnea caused by the loss of airway space. Then most oral device advance the mandible that pulls the genioglossus muscles forward. Then tongue is subsequently forward and upper airway space is regained, and snoring and obstructive sleep apnea that diminish or sometimes it's also eliminated. So that mostly the principal is the tongue protrusions, and these are the device treatment option, that is tongue retaining device and mandibular advancements device. And this is the study between the CPAP versus mandibular advancement device in the treatment of OSA. It shows 14 RCT that comparing the mandibular advancement device and CPAP significantly decrease the AHI and the N1 N2 per sleep. However, compared with the mandibular advancement device, the CPAP significantly decreased the SF-36 social functional score, which certain score are using for assessing the sleep effectiveness. So this forest flow shows that there was no significant difference in the excessive sleepiness after therapy between the two groups. Then the effectiveness of the oral appliance versus continuous positive pressure therapy. So that oral appliance significantly improved the RAM percentage in the severe group and ESS in the adjustable of this oral appliance group. And important thing, the patient's preference is also more in the oral appliance. So these are the phenotypes of responder to the mandibular advancement device in obstructive sleep apnea. That is the systemic review and meta-analysis, which is published recent 4 years back, 2020. That is 41 study including that. So the responder to the mandibular advancement therapy are then lower age group, females, lower BMI, small neck circumference, lower AHI, a retracted maxilla and mandible, narrow airway, and shorter soft palates. That's such phenotypes are responding very well with the mandibular advancement device. And now, what about the surgery and pharmacotherapy? So, surgery in highly selected patients, tonsillectomy, adenectomy, mainly in the pediatric patients, and sometimes it have huge and large tonsils. It also helps in the adults also. Then the maxillomandibular osteotomy, and at last, bariatric surgery in selected obesity patients. Pharmacotherapy that we'll discuss in later on, that depends on the pharyngeal collapsibility, some certain obesity drugs, certain that arousal threshold and the loop gain, that particularly oxygen supplement with the hypnotics, then the acetazolamide in therapy of the OSA and the comorbid OHS. So what about the bariatric surgery? So many patients who either undergo or recommended bariatric surgery that in the obstructive sleep apnea, and according to the American Society of Metabolic and Bariatric Surgery, that bariatric surgery and weight loss, it actually result in improvement in various parameters of the OSA. And there is a systemic meta-analysis of 69 study around in a patient of around 14,000 patients stated that over 75% of patients shows at least improvement in their sleep apnea. Then biliopancreatic diversion was the most successful procedure in that, in improving or resolving the OSA with laparoscopic adjustable gastric banding device. So in that conclusion that bariatric surgery is a definitive treatment for obstructive sleep apnea, regardless of what type of specific type of OSA. And this is another component of the hypoglossal nerve stimulation for the treatment of obstructive sleep apnea. So we all know that electrical stimulation of hypoglossal nerve, which is a motor nerve of the genioglottal muscle, that cause the tongue should protrude and stiffening of the anterior pharyngeal wall, and therefore it is an attractive potential therapeutic target for the obstructive sleep apnea. So the implanted system that use a stimulation of electrode, which is placed on a branch of right hypoglossal nerve, that induce the protrusion of the ipsilateral part of the tongue, then breathing sensing leads between the internal and external intercostal muscles that detects the ventilatory efforts, and implantable pulse generator located at a mid-infraclavicular region. Okay, so that stimulation which helps to relieve the pharyngeal collapsibility and helps to relieve the obstructive apnea. And the result of pivotal STARS trial shows that significant reduction in OSA severity, that around 68% without disrupting the patient's sleep. But beware that you have to particularly select the certain patients that BMI should be less than 30 and AHI between 15 to 50. Nowadays, they try to involve the AHI around 60, 65 also. And that should be exclusion of the complete circular collapse at the palatal level during the DICE. So neurostimulation for for stability of the upper airway during sleep or introduced as an option that I mentioned. And DICE and the fluoroscopy studies has shown the retrolingual and retropalatal space enlargement with the hypoglossal nerve stimulations. Now, what about the medication? So today there are no medications that are licensed for the pharmaceutical treatment of OSA. Much efforts has been made to improve the upper airway patency pharmacology that is improved for the management of the obstructive sleep apnea. But a large body of studies that it is not helpful, and some agents that produce an improvement to have a direct or indirect effect on the sleep and respiration. So only this medication should be for the who are not too good candidates for the CPAP, not good candidate for the oral device, and who are not ready for the surgical procedure. And there is one published study that combination of atomoxetine and oxybutynin that reduced the OSA, that was trial published. So atomoxetine has only moderate effects on AHI when administered alone, but when you combine with antimuscarinic oxybutynin, that helps to reduce AHI 62%. So in a recent 4-week randomized controlled trial of carbonic anhydrase inhibitors, that is sulthiamine, 68 patients with moderate to severe OSA, the AHI was reduced by 41%. The important thing is comorbid disorders are also a potential target for the drug therapy in OSA, that's including weight-reducing drugs and antihypertensive. Limited study has been showed about that phentermine or orlistat, that is a gastrointestinal lipase inhibitors, liraglutide, that is a glucagon-like peptide 1 agonist, metformin-added liraglutide, and empagliflozin, that in US that they did some trial about the anti-obesity drugs. And these two drugs, which is recently in the coming in the highlights, that pitolisant, that is a selective H3 receptor antagonist, that inverse agonist that increase the histamine synthesis and release that leads to promoting the wakefulness. And then the another thing is solriamfetol, that is a dopamine and norepinephrine reuptake inhibitors, which also show beneficial result in the OSA. So these drugs open new therapeutics window for patient with phenotype of residual excessive daytime sleepiness, and may improve the quality of life and daily performance at work and on road, especially if administered in well-selected patients. And that is this the future, the pharmacotherapy of apnea by cannabimimetics enhancement, the PACE clinical trial, that effect of dronabinol in obstructive sleep apnea. It shows that improve in the self-reported sleepiness, then the greater overall treatment satisfaction, but large large scale of clinical trial to be needed to its use in a OSA. So these are that option, the OSA targeted therapy, that muscle function therapy, anatomical therapies, loop gain therapies, arousal threshold therapies, which is beyond the CPAP therapy. So now the role of clinical and pathophysiological trait in treatment selection for OSA, that is OSA, that clinical phenotype traits and pathophysiological phenotype traits, in that the lifestyle, drug therapy, CPAP, surgical option, and pathophysiological, that you can use the alternative device, CPAP, nerve stimulation, drug therapy, and for the loop gain, you can use the oxygen therapy also. So in concluding that treatment of OSS traditionally target the anatomical trait, this approach includes the CPAP, oral appliance, upper airway surgery, weight loss, and positional therapy. But however, new and emerging therapy that target specific phenotypic or treatable traits show kind of promise in an alternative to the traditional therapy. So sleep apnea hurts, but the cure doesn't have to freedom from the PAP therapy, at least for a few. Thank you very much.
Thanks, Dr. Gopal, for the very enlightening and showing all the lights of the other aspects beyond CPAP, the treatment of OSA. My request to our distinguished audience, can we would they like to ask any question, any queries, Dr. Gopal Rao?
Yeah, yes, I want to ask a question.
Yeah, Dr. Padar, carry on.
Yeah, sir, please, can you put more insight on myofunctional therapies of treatment of OSA?
Myofunctional therapy, we run a sleep clinic at our clinic. So in that, we involve the particularly cardiopulmonary physiotherapists to train the patient for the that is the observed physiotherapy. In that we improve the upper pharyngeal that muscles training, breathing exercise, and endurance of that muscle should be improved, and that helps. And we include in that all kind of that behavioral, positional, that kind of therapy we explain the patients, those who are not willing to go for a CPAP therapy.
And how long they should need to do this myofunctional therapy for getting some significant results?
At least 4 to 6 weeks is needed for that obviously improvement or symptoms relief that we need that. Though we have not followed that sleep study, but now I'm planning to do that, the patient on myofunctional therapy, and we repeat the sleep study, and we can see that how much improvement is seen. That is just subjective observational improvement what we will find. And we have seen that number of patients with that therapy, the number of snoring episode is reducing. We also call the spouse also for the scoring system.
Okay. And sir, one more question is there. If we go for the holistic approach, like if we combine this myofunctional therapy with CPAP and weight reduction regime, so I think the pressures required for CPAP might be reduced. What were there previously?
Obviously, there's, as a pulmonologist, we are using a lot of holistic approach in other airway disease also. So with that, and I am also running, I have experience of pulmonary rehabilitation for last 20 to 25 years from the institute where I'm getting the training, and we are running here also pulmonary rehabilitations. So that helps a lot.
Sir, is there any scope for finding a research gap to do a research on this topic, like doing a holistic approach for?
Definitely, we'll be in touch, and Dr. Nurul has my number, so we'll be in touch, and we can plan it out so we can have a data, because without data, nothing is visible. So that is the most important thing.
Okay. Thank you very much, sir, for your enlightening session.
Thank you.
I particularly liked your different ways in which we can approach OSA patient.
Thank you.
All the sessions are very good, and it intrigued my mind to do some research work so that we can apply all this holistic approach for the treatment and improving the quality of life of the patient.
Obviously, and at last, I just mentioned that mental and physical health is most important, not pertaining to the obstructive sleep apnea, sleep disorder, but all kind of disorders. So that thing has to be improved by this approach. That is the combination.
Yes, a point.
Yeah.
Yes, a point well taken, sir, from you. Thank you.
Thank you.
Thanks, Dr. Gopal, for sparing your precious time and coming to us, joining from Ahmedabad and sharing your thoughts. We are really thankful from all our organizing committee of International Sleep Medicine Congress 2024. With your permission, we are moving to our next speaker, Dr. Anamika Singh.
One thing, Mr. Nurul.
Yeah.
Please, with the permission of Dr. Gopal, you can share his number with me so that we
Sure.
can.
I'll share Dr. Badr. I'll share his number.
Thank you, Dr. Badr.
Yeah.
All the best.
Yeah.
Sure. Thank you.
Yeah. Dr. Badr, I'll share Dr. Gopal's number after this, event. Yeah.
Thank you.
Yeah. Okay. Okay. Thanks, Dr. Gopal. I'm moving to the next speaker, Dr. Anamika Singh. Dr. Anamika, can you unmute your microphone? Yes, you are there.
Yes, sir.
Okay. Okay.
Good afternoon,
So,
sir.
yeah. Very good afternoon. You are visible and audible. Let me introduce you, and then you can share your slide, and then we'll move forward. Yeah. So, Dr. Anamika Singh, she is a professor in Department of Physiology, Uttar Pradesh University of Medical Sciences, FI, Etawah, UP. She did his graduation MBBS from KGMC, prestigious King George University now, in 2005, and he did MD Physiology from GSVM Medical College, Kanpur. And she is a registered polysomnography technologist from BRPT, USA. She is in academics, had teaching experiences more than 1.5 decades. And she has established a sleep lab and sleep clinic at Uttar Pradesh University of Medical Sciences, FI Ottawa, and conducted more than 200 polysomnograph and titration studies. She is life member of National Academy of Medical Sciences, Association of Pharmacologists and Physiologists of India, Association of Physiologists of India, Indian Society of Sleep Research, ISSR. And she did research, a lot of research work. Actually, she has 25 research papers published in national and international journals. She did a research project thesis, 4 as PI and 4 as a co-PI, and guided 6 PGs in the thesis research work. Attended and presented papers in various national and international conferences. So if I missed anything, Dr. Anamika, you can add on. Apart from that, she has a award with Neuroscience Research Award in the field of physiology and Scientist of the Year 2020 in the field of physiology. So he has organized multiple events related to sleep CMEs, etc. in the past. So with this brief introduction, over to you, Dr. Anamika. If you want to add anything in your introduction, you can add, and then you can share your slide and you continue your presentation.
Sure, sir. Thanks a lot, sir. Now I'm sharing my slides.
Mhm. Yes.
Is it visible, sir?
Yeah, it's visible. Could you make it? Yeah, it's much nice here. Yes.
Okay. Thanks a lot, sir, for giving me this opportunity to deliver my talk at this prestigious platform. So I would be delivering on the role of on the topic role of polysomnography in OSA patients. Sir has covered much of part of my talk. So I will be discussing very basic from very basic to the until the use of polysomnography in OSA patients. Now I am starting with the very basic. Sleep is a basic human need and it is essential for good human and good quality of life and performing well during the day. Of course, sleep consists of two types of sleep, NREM and REM sleep. NREM is required for somatic well-being and REM is required for mental well-being. And sleep, if we contribute to the if we practice sleep hygiene, we may influence the sleep quality as well. Excessive daytime sleepiness is most common presenting symptom of OSA. How we regulate the sleep? It is regulated by two process model. One is a homeostatic process model S, and other is circadian process C. Homeostatic process model S influenced by experience duration of sleep and wakefulness, and circadian process is basically governed by pacemaker, intrinsic pacemaker, which is situated in suprachiasmatic nucleus of hypothalamus. Now coming to the characteristic of sleep. Sleep characteristics include sleep architecture, duration, quality, and regularity, and timing of sleep. So we will be discussing one by one. Sleep architecture. It consists of non-REM sleep and REM sleep. Non-REM sleep consists of N1, N2, N3, and REM sleep and then wakefulness. Now come on to the distribution, how they are distributed. Non-REM sleep, it consists of 75 to 80% of sleep, and which among non-REM sleep, it has 3 to 8% of N1 and 45 to 55% of N2 and 15 to 20% of N3. 20 to 25% it consists of REM sleep, which is also known as paradoxical sleep. Total sleep cycle duration is 90 to 110 minutes, In first half of life, there will be predominance of N3 sleep, and in later half of night, there will be REM sleep. REM sleep increases as the duration of sleep increases. That is predominantly present in later half of night. So if we talk about the architecture in elderly patients, in elderly subjects, in elderly age group, N3 will be decreased and number of awakening increases, circadian rhythm become advanced, and patient sleep early and wake up early in the morning. Now coming to the duration of sleep, it is recommended by sleep duration National Sleep Foundation. Sleep duration it is different according to the age group. In newborn, it is 14 to 18 hours. They need 14 to 18 hours. But in school age children, they require 9 to 11 hours. In adults, they require 7 to 9 hours. And in older age, they require 7 to 8 hours. Duration of sleep decreases from newborn to old age. As the people become advanced in their age, sleep need does not decreases. Each individual need can be different. So optimal duration should be 6 to 9 hours. Now coming to the sleep quality. Sleep quality is assessed by subjective evaluation and objective evaluation. Subjective evaluation, it is performed by the Likert scale. Likert scale, if it is 1, it indicates very good sleep. If it is 5, then it indicates very poor sleep. And another tool is to detect the quality of sleep is PSQ1. That is Pittsburgh Sleep Quality Index. Now come to the objective evaluation. It is done by the various parameters: sleep latency, number of awakening, WASO, that is wake after sleep onset, and sleep efficiency. If the sleep latency lies between 0 to 30 minutes, then it is considered as good sleep. And it is if it is more than 45 minutes, then it will be considered as poor sleep quality. Number of awakening should be less than 1. WASO should be less than 10 minutes, and sleep efficiency should be more than 95%. Now coming to the sleep regularity. Sleep regularity can be assessed by 2 criteria. According to one criteria, it refers to going to bed and waking up at almost the same time. The parameter assessed standard deviation of sleep midpoint. I will discuss in the next slide what is midpoint. If it is deviated 1 hour, then it will be good regularity. If the deviation of sleep midpoint more than 1 hour, then it will be bad regularity. Now come on to the second criteria that consists in that is the parameters assessed sleep duration difference on workday and non-workday. If this difference is more than 1 hour or less than 1 hour, then it will be good regularity. If this difference is more than 1 hour, then it indicates bad regularity. Now come on to the sleep timing. As I told you, sleep timing, it refers to the sleep period in 24 hours time. It consists of sleep duration, parameter assessed as sleep midpoint. What is ideal sleep midpoint? It should be 2:24 to 3:30 a.m. in the morning. It's a good sleep time. If suppose you are sleeping at 10 p.m. in the night and you are waking up in the morning, then what will be the sleep midpoint? It lies between the approx in the midway. So if it lie between the 2:24 to 3:30 a.m., then it is ideal sleep midpoint. If it is deviated less than 1 hour, then it would be considered as good sleep timing. If it is become more than 1 hour from the mid sleep point, then it considered as bad sleep timing. There is huge list of sleep disorders. According to international classification of sleep disorder, insomnia, sleep, there is various category of sleep-related breathing disorder, sleep-related hypoventilation disorder, and sleep-related hypoxemia disorder, central disorders of hypersomnolence, non-REM related parasomnia, REM-related parasomnia, circadian rhythm sleep disorders, sleep-related movement disorder. Now come on to the we established sleep laboratory at UP-UMS FE. We are doing polysomnography here since last 2018, and we have conducted more than 200 sleep studies. Now, the indications of sleep study, polysomnography. Sleep-related breathing disorders can be detected by sleep polysomnography, and it is used to assess the treatment in OSA as well. Sleep-related behavior disorder can be detected by PSG, PEP titration in OSA patient. Atypical unusual parasomnia can be detected by using this polysomnography test. Narcolepsy, neuromuscular disorder, sleep-related symptoms, and seizures, periodic limb movements disorder can be assessed by doing sleep studies. Now, the types of sleep polysomnography, there are various levels of polysomnography. It depends on the how many channels we are using. 33 to 58 channel we use in level 1. 15 to 26 channels we use in level 2 polysomnography. Level 3 polysomnography with channel 5. 5 channels only there in level 3. In level 4, only 1 channel we use. Now, the types of polysomnography. There is diagnostic polysomnography. Just we use it to diagnose the AHI index and other sleep disorders. Titration polysomnography, split night polysomnography, multiple sleep latency test, maintenance of wakefulness test, multiple suggested immobilization test. Now, come on to the an approach to a case of sleep apnea. How do we identify the case of sleep apnea, and what would be the approach to identify this? One patient come at our sleep OPD. He was 51 years old, male patient presenting to sleep OPD with chief complaints of daytime sleepiness, witness apnea, forgetfulness, heartburn, and increasing weight. He is clerk by profession in Tehsil Itawa, UP. He used to do small mistakes in office and home due to his sleepiness. He used to put wrong notes in wrong file. He was losing interest in maintaining and developing relation with his colleagues and relatives, and his professional reputation was at stake. After seeing an article published, we have published an article in newspaper also. So when he saw this article about the sleep lab and sleep clinic, uh, he had consulted in the sleep OPD with his symptoms. Now, what we found, his weight was 108 kg. He was obese. Height was 183 centimeter. BMI was 32.2 kg per meter square. And what the schedule on weekdays, he used to go to at bedtime at 10 p.m. and weekend at 10:30 p.m. Wake up time was in weekdays 6:30 a.m. and wake up time at weekend little bit longer. So it was 7:30 a.m. Naps infrequent on weekdays, and weekend 1 to 2 naps on Sundays. On weekends, her dinner time was 8 p.m. on weekdays. Dinner time was 8:30 to 9 p.m. on weekend. So sleep onset latency was 15 to 20 minutes on weekdays and 25 to 25 minutes in weekend. Now, come on to when we did the insomnia evaluation on this patient. So there was no insomnia problems. So after that, after doing the insomnia evaluation, we did OSA evaluation. Yes, he had snoring problem. Frequency was more, and the volume was medium. Length of the duration of the snoring was more than 10 years. Snore arousals were there, and the worsening factors, he was alcoholic, and the position, he used to sleep in supine position. Fitness apnea were there, gasping and choking arousals were there. Nocturnal heartburn also present, and nocturia was there. He used to go to micturition 3 times per night. Dry mouth history was there. Morning headache was there. And weight changes, yes, he was obese. According to Stop Bank questionnaire, score was 6. So he was lying in the highest risk OSA risk category. Now sleep evaluation according to ESS was 20 and drowsiness was there. To countering this drowsiness, he used to take caffeine more. Narcolepsy symptoms was absent. RLS evaluation when we did, there was no RLS symptoms, and now parasomnia evaluation was did. There was no symptoms of parasomnia. Past history, family history, there was no family history or social history. Yes, he was taking caffeine more. And when we did the systemic evaluation, there was only nocturnal urination and the GI symptoms. Heartburn was there. All the systems were normal range. And when we performed examination, he was awake but sleepy. Eyes were clear but droopy. And when we did the ear, nose, and throat examination, Mallampati score was 4. Heart palate high, long, medium, uvula, and tonsils were class 1. Tongue was non-scalloped. Dental examination was normal, and neck, there was no evident mass, and the respiratory rate was 16. Respiration was normal, and all the systems were normal. Now come on to the neurological examination was normal, and the psychiatric examination when we performed, then he was alert, but orientation grade was 4, euthemic. Now come on to the differential diagnosis. When we, on the basis of symptoms, we have I put this patient in this, there are so many differential diagnoses on the basis of symptoms. I kept only the OSA in priority. There is one study conducted on OSA, that is comorbidities, health-related quality of life, and work productivity among the people with OSA with excessive daytime sleepiness. What they found, there was 2 groups, OSA with excessive daytime sleepiness and OSA with without excessive sleepiness. So what they found, OSA patients with the excessive daytime sleepiness had worse quality of life. So the patients with the worse quality of life, they had more work related impairment. As in my patient, he was also suffering from forgetfulness, and he was keeping notes in the wrong file. So symptoms are matching. OSA leads to cognitive impairment also. The reason is hypoxia and the sleep fragmentation. Now come on to the probable diagnosis. On the basis of symptoms, I made the diagnosis OSA with excessive daytime sleepiness and obesity with cognitive impairment. According to the ASM guideline, so polysomnography is a gold standard investigation to detect the OSA. So this is the sleep laboratory at UP UMSFA, and this is a video showing the polysomnography hooking. The technician is preparing the patient for sleep study. So now I'm playing the video. Now the technician has prepared the patient for titration study. Now this is a study, diagnostic sleep study versus titration sleep study. When we did the diagnostic sleep study in the patient, and what we found, there were a lot of snore events, lot of desaturation, hypopnea, apnea. And when we performed titration study, all the events were washed out. So this is the comparative evaluation of diagnostic versus titration study. All the events are reduced significantly after doing the titration study. And diagnostic sleep efficiency was improved significantly, and sleep latency was also improved. Snore event were reduced from 235 to 78, and AHI index was reduced 63 to 1. And this is the data which showing the what pressure we have used. At least all the events were disappeared. Now the diagnosis, now following diagnosis is OSA with EDS with the gastroesophageal reflux disease and obesity. Now the how did we manage this patient? We planned gradual weight reduction by at least 20 kg and advised to him to avoid alcohol before bedtime and have dinner 2 to 3 hours before the bedtime. So according PEP therapy is uh, is the best to treat OSA in adults with the excessive daytime sleepiness, hypertension, and impaired sleep-related quality of life. So when we prescribe the auto-PEP with oronasal mask for 1 week, with setting auto minimum 4 centimeter H2O and auto max 20 centimeter H2O with EPR 3, RAM start 4, and humidifier 3, and call the patient after 1 week. When he came after 1 week in my OPD, then what we found, P95 was 14.1 centimeter of H2O, and auto minimum was 10 centimeter H2O, auto max was 18 centimeter. If all the setting was were remain normal, same. So this is the study which is conducted on the minimum range of pressure and the higher range of pressure range. So what we found, the lower span range of auto PAP setting were found to be as effective in correcting AHI as compared to higher span range. So there would be higher adherence with the narrow span of the pressure. So that's why we decide to reduce the pressure span of my patient. So patient response was ESS become 0, daytime sleepiness was disappeared, patient reduced his weight by 8 kg, he remains awake during the daytime, can drive without feeling sleepy, and acid reflux improved much. And this is the patient's PAP download, and 95 percentile pressure was 14.5. He used this PAP machine for 28 days for more than 4 hours per day. So these were the settings, and this is the sleep clinic at our institute. So what is the patient's response? You can hear by his mouth.
Anamika, the conversation is not audible in this video.
Okay, okay, sir. Now the last slide. I came to the last slide. What is a take-home message? So sleep time and the wake time should be consistent. Make sure your bedroom is quite dark, relaxing, and at a comfortable temperature. Remove electronic devices such as television, computer, and the smartphone from your bedroom. Use bed only for sleeping sex. Avoid large meal, caffeine, alcohol before bedtime. Get some exercise daily. Thank you, sir.
Thanks, Dr. Anamika Singh, for sharing your enlightening presentation. Anybody want to ask any question?
Yes.
Yeah.
Dr. Anamika, you in your patient's case, you said the weight reduction was seen.
Yes, sir.
So is this because of use of CPAP, or he made some other measures to reduce the weight?
Yes, sir. It is because he was not taking any medication to reduce his weight. So this is the effect of CPAP only. So what I observed, because I inquired this thing also. So this is the effect of CPAP only. He has reduced his weight significantly, no doubt.
What is the physiological basis of weight reduction using CPAP? Can you enlighten with this?
Physiological basis. Okay. When we use the CPAP, actually CPAP acts as a pneumatic splint. It keep the airway open so that patient can take breathe, or they can breathe properly when we when he use CPAP. So it can reduce his hypoxic event or improve the desaturation. Yes, sir.
Ma'am, this is Dr.
Yes, sir.
Anshu Sahu. May I ask one question? You
Yes, sir,
mentioned
please.
about the role of dentist. What is the dental role? Would you please be able to tell us?
Okay, sir. If there is any retrognathia or overjet in his facial, if any kind of facial abnormality in terms of maxilla or mandibular uh, abnormality, means if he has overjet or
Yes.
retrognathia, so we can improve with the help of dentist as well. Yes, sir.
We would like, yes, ma'am. Thank you, ma'am. My PG student, I'm a head of
Yes, sir.
department in Dental College Hazaribagh,
Yes, sir.
and my PG students is doing a library dissertation, LD, on sleep apnea. So will it be possible for your contact number, so that she can
Yeah,
contact?
sir. Sure, sir. Sure, sir. Of
I
course.
request you to share it with Dr. Nurul sir,
Yes,
and I
sir.
will request him to give it to us. Dr.
Okay,
Nurul sir,
okay.
will you kindly
Yeah.
share the numbers? Thank you, sir. Thank you, ma'am.
Thanks a lot, sir.
Thanks, Dr. Anamika, for coming to us, and because you are said that you are not well, and that's why still you are joined and you have made your commitment and all. So thanks again, and I request you to join again in our future events as well.
Thanks a lot, sir.
We are very thankful to all our organizing committee of International Sleep Medicine Congress 2024. I'm giving you thanks on behalf of all of organizing committee. There is a one and two announcement that we have one speaker in the morning, Dr. Arpita Priyadarshini. Her mother is no more. She left her last week only, and she is busy in her rituals, so she couldn't join. And then Dr. Nishant Goel is also not well, actually, so she couldn't join. He is a psychiatrist and is supposed to talk. So these are 2-3 speakers who are into our panel discussion, and they are the panelists. So we are not conducting the panel discussion now. So we come to the end of our session, the third edition of International Sleep Medicine Congress 2024. So with the permission, Dr. Anamika, we are requesting Dr. Anshu Sahu for the vote of thanks for this whole event, which is being spread in last 2 years, 16th and 17th of March 2024. And we have many speakers. We have touched all the specialty. We have touched, there are physiologists, psychiatrists, pulmonologists, orthodontists, neurologists, and ENT surgeons as well, those who have shared their thoughts. And it is the teamwork. Sleep is a interdisciplinary, medicine. So we should collaborate together. We should not work in silos so that we can early diagnose and give better management to the patients. We should, focus on early management, and we should focus on a conservative management of OSA as well. So with this note, over to Dr. Sahu. Dr. Sahu is the organizing secretary of this International Sleep Medicine Congress, and with his effort and his subordinates, Dr. Irfanul Haq, we are come to this wonderful Congress. Without his help and his guidance, it is not possible that we can conduct such a nice, virtual program. So over to you, Dr. Anshu Shahu, for giving the final vote of thanks. So it is your take now.
Thank you, Dr. Nurul. Thank you very much. Thank you, Dr. Anamika. It was a fantastic seminar that you presented. So, I'm Dr. Anshu Sahu, Head of Department, Hazaribagh Dental College, Department of Orthodontics in Jharkhand. And we are very thankful to Dr. Nurul Anwar sir, the CEO of MedSkill and the organizing chairman of the International Sleep Medicine Congress 2024. Dr. Irfan ul Haq, who is the assistant professor in Department of Orthodontics at Hazaribagh Dental College. He is the co-organizing secretary of Ismcon 2024. I'm very thankful to both of you, sir. Thank you very much for holding this webinars. It was excellent presentations. We are thankful to all our speakers, Dr. Vibha Gangwar, Dr. Anup Kumar Dhanvijay, Dr. Manjari Tripathi, Dr. Sapnai Rat Sridharan, Dr. Seema Sheikh, Dr. Kalpesh Talati, Dr. Reena Ranjit Kumar, Dr. Namika Singh, Dr. Sanjay Manchanda, Dr. Saurav Das, Dr. Gopal Rawal. We are also very thankful and grateful to the MedSkill IT team. Special thanks to Mr. Israfil Khan, Chief Technology Officer, MedSkill, and Ryan for smoothly conducting the virtual show. We are thankful to all the attendees and those who are present here, especially thanks to you to be with us till the end. Thank you all for joining us from across India and across the globe. We look forward that you will be joining us yet again when Dr. Nurul sir and his team makes this wonderful effort for the webinars. I would request all of you to please share your feedback at ismcon24@gmail.com. Thank you, Dr. Nurul. It was a fantastic presentation. I really had a wonderful experience personally, and I'm sure our viewers, our speakers, they all had a enriching time. Thank you so much. Looking forward to meet you again. Thank you. Have a great day.
Thanks, Dr. Sahu. There is with your permission, I'm just making one announcement that the e-certificate for our all, registrants who registered for this, they would be available on the same portal, ismcon.in, in 2 to 3 days. So today is a weekend, so the technical team is not working, those who are doing designing and all. So it would be available by, say, Wednesday or Thursday. So you can log into the portal ismcon.in, and you put your email ID over there, and you will get your certificate from there. So this is all from this third edition of ISMCon 2024. With the permission of all our audience and organizing secretary, Dr. Anshu Sahu, I am signing off for the day. If anybody want to add anything before signing off, they can unmute and they can share their opinion here. Otherwise, we'll signing off for the day. Okay.
Thank you.
Okay. Okay. Thanks, everybody. We'll join again on World Sleep Day next year, 2025, with more enthusiasm and bigger network and better show. Thanks, everybody. We are signing.
Thank you, Dr.
Thanks a lot,
Nurul.
sir. Thank you
Excellent.
so much,
Thank you
sir.
so